Good morning, everybody. Thank you so much for inviting us. I'm going to say us because it's Dr. Isabel White, Lynn Buckley, and myself who've had to think about this inventory for the UK and the service provision in terms of sexual oncology. My background is I'm an advanced nurse practitioner. I work at a specialist cancer hospital based in the northern part of the UK, in a place called the Christie Hospital. Some people may have heard of it. My background is in gynae, medical oncology, and I'm trained as a psychosexual therapist. In terms of how I'll discuss this kind of education around psychosexual work, but I'm kind of dual trained in that area, and I've worked, if any of you know Josie Butcher, I've worked with her for a long time as well, so real interest in breast care in terms of sexual oncology, and also prostate cancer, so those are kind of my areas of interest. So I'm hopefully going to cover the questions that were asked around the kind of provision for care, the guidelines, what education is there, information, funding for services, those kind of things, but obviously really happy to take questions either as we go along or at the end. So we obviously did do some preparation ahead of this, but I would just caveat to say that we haven't got, we don't know everything, and that's probably one of the greatest challenges, isn't it, of kind of keeping those networks healthy in terms of those of us who are specialising in this area, but actually making sure that, want to let you know that there's probably a wonderful work that's going on, but maybe in pockets that we're not aware of and we've not got that open communication. So that's a real driver for us, is to try and make sure that those of us who are working in the specialist area are talking to each other and sharing not just best practices but opportunities for research as well. So we'll go on to talk about that. So in terms of care and the key clinical reference, I'm sure you're aware we have our National Institute of Health and Care Excellence, our NICE guidance, and so many of the oncology disease-specific guidance will talk about sexual consequences of cancer, however not enough of them. So obviously it is there for prostate cancer as an example, and gynecological cancers, that psychosexual therapy and support and sexual oncology, they certainly phrase it from a psychosexual point of view, should be part of that provision of care for that person affected by that disease, but it's not, in terms of the funding for that, it's a recommendation and not necessarily the funding doesn't follow. We've also got the British Gynecology Cancer Society, the uterine guidelines, the cervical cancer guidelines. Information was published. I'm not going to go through them all, but there's certainly development around the kind of UK guidelines. But I just wanted to kind of broaden it out really, and to just mention that obviously clinicians from the UK have been involved in the guidelines for sexual health around prostate cancer patients that was published last year in the Journal of Sexual Medicine. But we've also got, and also Movember and True North and the guidance around that for prostate cancer patients. There were certainly some big contributors from the UK. In the UK, we have the pelvic obstetric and gynecological physiotherapy, which are definitely sort of speaking into this field and have more provision for people that are affected by cancer and offering specialist support in that area. We've also got our PRADA guidelines, which is best practice pathway for pelvic radiation disease, which has two specific areas thinking about treatment for sexual consequences of treatment for both male and female, and they came out last year, which is again really, really helpful guidance and also information for patients. And then we've got our Society of Radiographers, who are also supporting that kind of work and driving forward communication between clinicians, but also our integrated care systems, which is where the money is, supporting the offering there for our patients. So the kind of two main providers of kind of education in this area, although I will just say, there isn't a separate register for sexual oncologists in the UK. There isn't specific education platforms. However, we've got the Institute of Psychosexual Medicine, who originally, now they take AHPs and nurses, but previously that was just medically led. So that changed in 2021. I've trained with them and got my membership with them as one of the first nurses. So that's great, but again, not specifically around oncology. There are a group of us within that, who have those qualifications, but not a qualification specifically around sexual oncology. And then the College of Sexual Relationship Therapists. Again, these are not necessarily clinicians and come from all different kinds of backgrounds. And the psychosexual masters, therapy masters provision and offering in the UK is more broad than not just clinicians, but they will be accredited by the College of Sex and Relationship Therapists and consequently the British Association of Psychotherapists as well. So in terms of the provision of services for patients, there isn't sort of a consistency across the UK. This is the future of the UK. For those of you who don't know, Manchester is kind of in the middle below Scotland, there isn't, but we map locally where provision is, and certainly try and get those services provided and awareness of them. But a lot of it is kind of find me a therapist if you're looking for somebody, and it'll just be in their kind of information that will be around their interests. There's broad provision throughout integrated care systems relative to the commissioning for the oncology patients, as we've described through the NICE guidance, for example. There might be erectile dysfunction provision for prostate cancer patients, but that doesn't necessarily extend on to specialists offering psychosexual support. It's certainly not always delivered by a clinician, by a medical clinician. Was that a question or just? No? Okay. What I would say is there's been a notable reduction in provision. So we were certainly talking about that within our network of just how all the provision is and how hard it is for people to identify services, but also specialists who have a real interest in, like in terms of late effects. We've got general practitioners, so the people that community services where they would be able to refer, and there's an organisation called Relate who have got subcontracts and commissioning across the UK, but again, it's not consistent. Some sexual health services have some provision as well, but again, some oncology patients don't feel comfortable, or wouldn't necessarily make those associations, and that's one of the challenges in that particular area. So we've got the COSRAT, so College of Sex and Relationship Therapists, and the Institute of Psychosexual Medicines, and there's others that are providing. So Plessy Health is a digital online platform providing specialist services to oncology patients, and they have psychosexual therapists offering through them. We have also got our oncology disease-specific charities, which I will mention as well, and they'll have advisors for patients. But funding is challenging, as ever, and so it often falls to the patient to fund it privately. We've had some successes recently in our services in Manchester, where we've got some private health companies who are acknowledging that psychosexual support for patients affected by cancer can be part of their psychology and supportive services, and so that has been a real win for us in the UK. So education-wise, these will be short courses, study days, separate offerings that may be cancer-related. So I'll give you the example of the British Menopause Society. They have, treatment-induced menopause, specifically around oncology patients, and they'll provide some study days around that. Obviously, the College of Sex and Relationship Therapists will do, and Isabel White will have provided resources for that. There is a lot of teaching that goes on, but again, very sporadically in terms of I teach around sexual oncology on the masters at a couple of universities in Manchester, but that will be just, again, one day within their whole sort of 3-year training programme. The NHS, again, I'm noticing that this is an area of difficulty and challenge, will provide study days, but those who are invited and will be different depending on the kind of take-up and clinical restrictions as well. Charities are also providing that both for patients and for clinicians, which is exciting, and we're very grateful to them for providing those kind of platforms, and I'll talk about some of that. The Institute of Psychosexual Medicine do have a separate, what we call our initial training, which is specifically around sexual oncology. That will be about 9 hours of training, and then as a starting point, maybe offered to kind of clinical teams that are asking for that very specific provision. So in terms of our charities then, we've got a plethora, and we're very fortunate of, and this is not a comprehensive list, but these are some of the people that we've been working with. So we've got a lot around disease specifics. We've also got the Sex with Cancer, that is like an online platform in terms of raising awareness around sex and cancer, but also thinking about the more other therapeutic approaches, for example, arts and cancer, and just getting, they have a podcast and things like that, and they're just kind of getting that out there. Really great to see that work going on, and they are also providing kind of champions for sex with cancer in and trying to raise awareness around people being advocates, champions, being able to have some of those conversations. Macmillan, perhaps you've heard of, are a big cancer charity, and they do some work in this area as well. Live Through This is a cancer charity for LGBTQI+, and they specifically talk about the kind of sexual consequences of cancer for people, and how they might get some specialist provision. And the others I'm sure you're aware of. So in terms of our research then, we have some research, as we said, many contributors from the UK will contribute to much more international guidance and research. And again, there'll be lots going on that we don't necessarily know about, but I would say the majority of it is going to be small scale studies that are medically led, usually an intervention based, especially if it's funded by pharma, and therefore we're looking more at the space of erectile dysfunction as an example, where we're looking at treatments rather than they may include quality of life measures, but not always, and so that's a real challenge for us. We've got a narrative really from both the government and from other charities that speak into this space around living with and beyond, which obviously is something that is worldwide around the survivorship issue for patients and people that are living longer, either with treatable disease or curative disease, but living with the late consequences. And so there is quite a lot of funding and drivers around quality of life measures and thinking about management of late consequences. And so some of that will be around awareness raising, around speaking to people who are affected by cancer and their sexual consequences. And this kind of wellness narrative, and there's definitely some appetite there. However, we're not seeing that coming down through funding or through provision of services or through education as well. So funding is poor for research. There is a single pot of funding or pots of funding. It would be more in the kind of wider open space, and so that kind of makes it really challenging as well, because you're competing, as many of you know who work in oncology, with a great many other priorities in terms of our patient care. And we need to do more in terms of raising the patient voice around what they want, and the fact that they're really keen to have more research in this area. And then, well, lastly, I just wanted to mention about genetics. So this is an area of my specialist interest. So looking at, as we move into a space where we are much more aware around our people's genetic risk, what is coined as the kind of inheritance guilt, and the consequences that has on individuals and their perception around their sexual well-being and sexual life, and sexual consequences as well of things like prophylactic surgeries on body image, and also oophorectomies and treatment-induced menopause. So my area of interest was in ovarian cancer, looking at differences in risks and experiences, sexual dysfunction experiences of people with BRCA gene mutation and those without. And there's a number of other factors that are included in that, but I do think it's an interesting area, and I'm curious to know if there's anyone else who's doing work in this area. So I hope that's okay. I'll stop sharing and I'll take any questions. And I hope we had no problem.
Yeah. You can't hear you, probably go to the computer. Just one moment.
Yeah. I don't know, I'll start. Thank you so much for this, well, I think elaborate, maybe not all comprehensive, but you searched all these things together from your country. And I was wondering, you started with the guidelines. In the guidelines you have in England, do you have special modules for sexual health, or is it all incorporated in the guidelines, or does it differ per guideline?
It is different per guideline, and so I would say it's different whether you're looking at the national, the NICE guidance versus, say, for example, the British Gynecological Association for Uterine Cancer. That goes into kind of late consequences of radiation, brachytherapy, all those kind of things. So we're looking then at, okay, what is the provision here? So it would be embedded within that, rather than kind of segregated out, if you like.
Oh yeah, and are there any guidelines with special modules? I call it a module, but I don't know.
Yeah, I would say, sorry, I'll go back and have a look at my name, what I put on there. So yeah, sexual difficulties after pelvic radiotherapy was written by Isabel, and that was published in the and so that led on to more international guidance, but not nothing specifically in the guidelines.
And you said, well, of course, there's always like nooks and crannies, people working somewhere, and like, oh, they're also doing so. I don't know if we already talked about this on the mail, but do you have a connection with, because you also, of course, are connected within your institute for like sexology, and but do you, and you said, of course, there are separate groups that are kind of focused on oncosexology. Are there already kind of like groups or connections, or?
Yeah, I think that's what we sort of said. Actually, there isn't. We haven't got a structure around that specifically. It would be within your association with either the institutes like sexual medicine or COSRAD, and then obviously others like urologists, gynecologists with an interest in. But we're not coming together, in a structured or meaningful way of that people can kind of take membership of those things and have a forum to discuss research, etc. Everybody is perhaps working, the urologists are working with the urologists, the gynecologists are working with those, and we'll bring in like the Society of Radiographers and pelvic health, physios, those kind of things. As I know was mentioned yesterday, how brilliant it is to have that diversity and that MDT approach. Great, but we do need to know who each other is. I think would be really helpful.
We have also a question here, Faisal El Kak. Maybe you want to come here?
Yeah, so can you hear us, Julia?
Oh, Faisal, come here, then you are
Okay.
seen.
Yeah, we cannot hear questions from
Okay.
the room.
Sorry.
Thank you very much. I have two questions. The first question is, for example, when you want to train or sensitize the providers about the issues of sexual dysfunction, what are the basic modules you start with to engage them, whether they are, the oncologists in general, let's say GYN oncologist or general oncologist. And on the other hand, the other question is, how do you initiate the demand? I'm a gynecologist. We're having this sexual health program at the American University of Beirut in Lebanon, and we're starting oncosexology within this program. So also, how do you initiate the demand in women, let's say in our case, or in men in general and women? Especially they are overwhelmed by the diagnosis, and then they are overwhelmed by the chemo, radio, surgery, and all the survivorship thing. So how do you create demand that they have to position their sexual function in the course of survivorship? Okay,
So
thank you.
Yeah, I'm just going to clarify your question. So one is around how do you engage with other clinicians that should have some interest or motivation to offer and associate themselves with those sexual oncologists. Is that correct?
Yeah.
Yeah. And the other one was around patients and how do you help prioritize or offer. Yeah, okay. So the first one, in terms of clinicians, I think it is about taking opportunities where they are. So if they're doing their own sort of study days, a lot of people just want some hints and tips. It's not difficult, but I think we obviously know that clinicians, and there's been some great work done on this. What are the barriers, and so you start by addressing those. Why is it that you don't talk about it, and presenting the evidence that says actually people need you to bring this up. They don't want to bring it up themselves, and also how do you make this a normal part of your care? So I am doing some work with the University of Manchester with their pre-reg medical students, as an example. And one of the challenges there is actually they have, say for example, they have in their gynecology area, and then they have a very narrow bit on gynecology, and then it's a case actually about a cervix patient, and then I'm saying, okay, so how do we bed in that actually this is a general part of care? And so it's that kind of integration and opportunities like that.
Okay.
I think that we shouldn't underestimate how uncomfortable people feel about raising these questions, and everybody's culture will be different. But I think giving people and upskilling people and giving people the opportunity to just practice that and have a bit of a dialogue around what can they do. And the big thing is, where do they send the patients? So if we can kind of answer those questions, people feel more empowered to speak to their patients. Gives them permission, as we know.
Yeah.
In terms of patients, what I would say is I think it needs, we have something that we in terms of our holistic needs assessment, which, there will be many across the globe around different people that we would say this is something, but we would also think about when we're going to introduce this topic. So we would say this might be something that you have some difficulty with, and we would want to support you with that. And generally, I think that it does come under. So, for example, some of the inroads is around menopause care. For example, if you've got treatment-induced menopause, that's a really good inroad, and you can just keep it nice and tight with that. But I think we also just need to recognise that patients also feel embarrassed about it. So it's normalising it. It's offering some support, practical hints and tips.
Or at least let them know that you have a safe space to express anytime you feel comfortable talking about it. Thank you very much.
Our presentation?
Yes.
Yes. This one. Okay. Can everybody see the presentation? Okay.
Yes.
Okay. Yeah.
Yes.
Can you still see it? The presentation? Yes? Okay.
Good morning, everybody. Thank you, Marianne, for inviting me to come here. I'm going to present the Danish situation. So, just to give you some facts about Denmark, we are a very small country, 5.8 million, but we have a long lifespan. Medium for men is 79.6 and 83.4 years for women. We have an extensive health care system. All consultation, blood tests, surgery, treatments are fully reimbursed by the taxpayers. The only thing that patients have to pay is medication, which is partially reimbursed. So, myself, I'm a gynecologist, and I am head of a department where we treat people who are having sexual dysfunction after various cancer diagnoses. So that's my background. In Denmark, we have had the cancer plans, which are regularly launched by our parliament since 2000, aiming at increasing survival of cancer. And these plans are supported by increased funding. The politicians have been worried that more Danes died from cancer than in any other Nordic country, so we were at the bottom of all statistics. So the plans are very ambitious and have given much attention in the media and the hospitals who are obliged to adhere to these plans, and they are measured how they are doing. So what is important here is focusing on shortening the time for diagnostic treatment, the process and the start of treatment. The Cancer Plan 1 came in 2000, and the focus of that was, I'm sorry, I cannot see my,
We don't
because...
see the presentation either, we don't see the slides shown for.
Yeah, so I think you have to move the gallery or put it away.
Okay, hide it like
Yes, yeah, that much better.
1 second, they said they can't see the... You can see the presentation?
Yeah, but
We
it
can
was
just
skewed
see
by
the
the
first-
photos.
the first
gallery.
page.
But not in presentation mode.
Oh,
The gallery was
but-
in front of the text.
no, they saw it. Can you have it like this, because
Yes.
otherwise they won't be able to see.
Good.
Okay?
In the cancer plan number 1 was in 2000, and that focus was elucidating epidemiology in comparison to the Nordic countries. What was the difference? Why did we manage so badly? And it was followed by an increasing capacity regarding all aspects of treatment. In the Cancer Plan 2, which came in 2005, the focus was on strengthening the prophylaxis and early detection. And Plan 3 in 2010 was improving the primary healthcare outside hospital, and also the palliative care. And the next cancer plan came in 2016, is the current cancer plan we're working on, and it's called the Patients Plan. Here the goal is that fewer Danes should experience cancer, and we should increase the survival rate, have a smoother treatment pathway through the hospital, shorter waiting list, and much more patient involvement. Sorry. Yeah, okay. Yes. So the current plan is to become a leader in the Nordic country in 2025. And in 2030, all adolescents and youth should be non-smokers. We want to have a generation of non-smokers. That's not going so well. We also aim at having 90% of all cancer patients should experience that one specialized doctor has the overall responsibility for the treatment pathway. So you have a specialist who is your personal doctor in this. Also, other things that we could mention is that there is a very heavy focus on patient involvement and also specialized care for the young patients who have been forgotten a little bit before. And there is an expression that we should have a good life after cancer, and this encompasses sex life. Also, we try to collect data on persisting cancer sequelae. I'll come back to that. So if I should take an overlook at the care, as you saw, we have these cancer plans. Regarding how many sexologists or consultants we have working in the field that Ilani asked me to say something about, it's very difficult because sexologist is an unprotected title, just as financial advisor, that's another unprotected title. So anyone can call himself or herself a sexologist or financial advisor. So many doctors and nurses seek education in communication in sexology. Unfortunately, lately the psychologists who have been employed at oncological departments have been fired because of reduction of the funding for the hospitals. Well, what about the social map that we can refer patients to? Well, the patients are encouraged to contact the municipality for help. So it's not centralized. It's in the 55 different municipalities in Denmark. But we have the Danish Cancer Society, which is a very powerful NGO, and they have counselors educated in sexology that the patients are encouraged to seek. And some hospital departments have specially trained nurses who take care of this. So, and as I said before, all this is tax paid. Lately, there has been made approaches to create specialized clinics that offer sexual counseling and perform research. And the first clinic was established in 2017. And initially it has been for colorectal cancer and breast cancer, but now it's for any kind of cancer, but not all regions have it yet. So what about the education? Well, there are several ways you can get your education. We have a master program in sexology at the Aalborg University, which was initiated by me actually in 2013, 60 ECTS. And to have this education, you need a bachelor degree or more, or be a healthcare professional or a psychologist. 2 years of work experience is mandatory, and this gives training in history taking, scientific approach, evidence-based learning, and you end by making a thesis which you have to defend orally. And we take in approximately 25 to 35 students every second year. In the Nordic countries, we have an association that's called NAX, where you also can have your education, and in Denmark it's a Danish association for clinical sexology. And this is a less scientific approach. It's more hands-on, more role-play, therapeutic theories and skills to give the students training in the implicit model. Yeah. And finally, of course, people take the ESSM education, which is, I think, an excellent approach to update doctors and psychologists in this. We need, though, an education for nurses, I think. Well, what about education for more generalized professionals? All MDs who are trained in general medicine, they have a short mandatory course in sexual dysfunction, and it's only about 3 hours, so it's short. Pre-graduate medical students, they are offered courses in sexology, and every university has its own strategy. In Aalborg, it's a mandatory 6 lectures plus cases presentation. In Copenhagen, it's 4 weeks voluntary summer school, and in Aarhus, the summer school, which is together with the psychology students. Well, what about the books? We have made a very large book, 1,056 pages on sexology, which was published in 2019 and revised and published again in 2022. And it also addresses LGBT patients with cancer. And I will always mention LGBT when I make a presentation because it's so overlooked. And then I can see Wout is here also, and Wout has been the editor of this book, which came in 2017 in English, with a multinational board of authors, and, which I can recommend. And also this book addresses LGBT patients with cancer. And in Denmark we also last year this handbook for sexology for nurses was published. It's a short little book of 182 pages giving an overview. Regarding research, we have made this large sexus survey, which invited 200,000 Danes to talk respond to questions regarding health and sexuality and identity. And there are ongoing publications. I think the group already published about 10 papers about this. Very interesting. So I made a quick search on PubMed to see how many publications has come from 2020 until today on sexual problems regarding to cancer in Denmark. And this is what I found. So of course you will have these slides so you can see it. So 12 about female sexual dysfunction and 19 about male sexual dysfunction, and rest about both genders. So thank you very much for your attention.
Thank you, Astrid, for your talk.
Are there any questions in the room to this great presentation from Astrid? So actually my impression was, Astrid, that Denmark is a very progressive country concerning cancer. You did a lot.
Yes, we thought so, and we thought these cancer plans worked very well, but then lately, during the last weeks, we have a huge scandal where hospitals actually hid that they had a problem regarding waiting lists, and they didn't tell the politicians. So now it's a shitstorm.
I understand. Understand. But a lot is going on in Denmark.
Yes.
Yes, very, very interesting. And how do you see? Yes.
Yeah. We have a question from the audience.
I could tell you, Astrid, you could say.
You repeat the question.
Just have a look.
Yeah.
Yeah.
We have a question.
Otherwise you need a hand. Astrid, it's a very simple question. You seem to describe what looks
Close.
You seem to describe what looks from the outside like a really coherent and smooth pathway in terms of sexual health and oncology. But then the one sticking point seems to be and maybe I just missed what you were saying, is that it's still left then to your patient to actually source their help. So, to have to, in the middle of the distress of a diagnosis and treatment, it's then your responsibility to seek out help. And that feels so unfair.
I totally agree with you, and I think the double taboo is working, that the patients, they think they have to concentrate on survival, and they should be thankful for surviving, and so mentioning a sexual problem feels awkward, and the doctor or nurses, they don't have time to take up this question, so it might be forgotten, but I think almost all cancer patients in Denmark are in contact with our very large NGO, the Danish Cancer Society, and there are various groups that takes up sexual dysfunction. So I think the patients who are in contact with the Danish Cancer Society, they cannot avoid talking about sex. So I think they are not met with the needs in the hospital setting, but it will be taken care of later. That's my impression, at least. In my own department, we have prostate cancer men, and they are offered group therapy. And those elderly men, 50 and 60, from a rural area of Denmark, they absolutely don't want to talk about feelings and emotions. So when they are there at the first meeting, they are sitting with their arms folded, yeah, and then not going to say a word. And then our therapist always says, I'm going to get some coffee now. You can just start talking when I'm gone. And when she comes back, they're just chatting and they're talking about everything, incontinence, erectile problems, and so on. So, yeah. Yes, thank you.
So, thank you very much, Astrid. So the next on our list is Annette Hasenburg. Annette, may I also ask you to introduce yourself, please?
It's my pleasure.
Yeah, thank you.
Hello to everybody. First of all, I would like to thank you for your initiative to bring us together for evaluation of oncosexology and for, let's say, integration of this topic into our countries. I'd like to introduce myself. My name is Annette Hasenburg. I'm the head of the Department of Gynecology and Obstetrics at the University Mainz in Germany. My specialty is, surgery for patients with gynecological cancer. I was trained in the United States. I did a fellowship over there. Additionally, I have a training in psychotherapy, and one of my main interests is evaluation and improvement of quality of life for my patients, including sexuality after cancer. And therefore, I would like to look with you into the details through the magnifying glass. What is the actual status in Germany? We have different guidelines that incorporate sexuality. These are as 3 guidelines on the highest level for breast cancer, endometrial cancer, ovarian cancer, cervical and viral cancer, with different topics. Like some guidelines have only the evaluation of quality of life, others recommend counseling or exploration for sexual problems, and of course, multi-professional interdisciplinary support. What about care? It's really difficult because we don't have a special training in oncosexology, and it's difficult. We have no special training as sexologists. We do have trained nurses, breast care nurses, and pelvic care nurses, which are trained. But we don't have any social map, and we have no special funding. It is paid by our DRG system. Education. We just started with a certified education in sexual medicine, which does not concentrate on the special aspect for oncological patients. But we do have talks, lectures, workshops, webinars, especially on large conferences of our professional societies. And there we do have special information and training for our healthcare professionals. We do have 2 books. One of the book, Sexuality After Gynecological Disease, was written by my team and myself, and the other one was written by gynecological oncologists, and it has a special chapter for sexual medicine in gynecological oncology. There are different articles, mainly of my team in Germany. Here only a few, like sexual activity and quality of life in patients after treatment for breast and ovarian cancer. Many of those articles are in Germany. It's very important to talk together. It's one of the main messages. Sexuality after breast cancer, what do we have to think about? And then we started to evaluate fertility sparing surgery and quality of life in women with different kinds of ovarian cancer. We have different brochures and flyers for our patients from different societies. I could find one Instagram account and one blog. So there's not too much. For my own team, we do have to work on 2 issues with 2 promotions: sexuality of partners of women with breast cancer and sexuality of patients with dysplasia. But my focus today is mainly on gynecological oncology, so I cannot tell you about patients with prostate cancer, for example. But I think it's very important, and this is a picture of one of my patients. She had some psychotherapy with me, and she tried to focus on her problem, and she tried to come to the left side, to the sunny side, and to escape the dark side. And I think this is our main focus, to bring our patients on the left side to the sunny side for quality of life. And I think it's very important to address this as an important issue of quality of life, because as it was already addressed before, it's very difficult to get started to talk about the problem of sexuality, because everybody thinks patients have to be glad that they survive. Why don't we have to care about sexuality? And we have more and more young patients with this disease, so we actually have to address this problem. I'm very, very happy that you started this initiative, that we can share our opinion, share our experience, and try to get the issue forward of sexuality for patients after oncological disease. Thank you very much for integrating me in this very interesting and ambitious group. Unfortunately, I have to leave this group soon because I'm at a conference in parallel, but for sure, if you have questions, I'm more than happy to answer your questions.
So thank you very much for Hasenburg. Very interesting, the situation in Germany. And I wanted to ask you, did the curriculum in sexual medicine already start? They spoke such a long time in Germany about this curriculum. Did it already start now?
It's on its way. It started in Berlin and Hamburg, as far as I know, and we try to get it on the road in Mainz. We have applied for it.
Okay, super. Are there any other questions within the room for Hasenburg? No. So then I think we come to the next speaker, and it is Anita Paulsen. Anita, could you please introduce yourself? And
yes, I'll do that, and I'll share at the same time, so we don't use the number. Okay, just first, I'll just thank you so much for the invitation. I'm so happy to be part of this group. I think it's 2 years ago when I talked to Roat about the oncosexology, and I said, I really want to do this in Norway. And remember what you said, that I think you're too small. You have to be a Nordic group and collaborate, and of course we can always see to Denmark. But as I've been trying to find what we're doing in Norway, I think actually we could be a subgroup in the subgroup in Norway too, because things are happening, and I'm so happy about that. And I'll just have some examples in my presentation, because until this day people have been texting me about articles and everything they do. So that's really good, I think, especially in the care. What I can see is that everything is really not systematized. It's just everybody sitting on their own, in their own top, on their own hospital, on their own research department, doing things. So we need to gather together and get a group. I am really new in this area according to research. I started my PhD 3 years ago, and it's on time called sexology. I just put my favorite subjects together. So we have done an intervention on this group, putting nurses into follow-up care, and my articles are around that. So I also have been working as a sexual counselor in a small hospital in the south of Norway for the last 16 years. and I've always had the interest of this. I see mostly gynecology, breast cancer or prostate cancer patients in my clinic. So a little bit about my country, which is really, really long. We are a little bit less than Denmark, 5.5 million people. And as you know, these days, I think half of the cancer patients are, almost half of them are prostate, breast, lung, and colorectal cancer. But also, every fourth woman who gets a cancer diagnosis is gynecologic cancer, if you put them all together in a group. And I think it's about every third or something are surviving, which means that we are really having a lot of people with lots of late effects and also into the sexual care. So I think also that's why this area has been growing. What we do have in Norway is that we have a really good public health system, or we like to think we have a good public health system. It's really falling apart these days. A lot of good healthcare providers are going into private care, and we have this really, really big discussion on how we're gonna take care of the public system that we are really proud of. If you have a cancer diagnosis in Norway, you get straight into what we call pakkeforløp, which I have translated into a care pathway. You have, from day one, you have this service that have to support you through the whole cancer care. So that's a little bit about that. Today we have actually, I think we are about 40 hospitals in Norway. So 11 hospitals now have sexological counselors. I'm one of them, and Sophie also. And when I started in 2007, I was the second one. So there has been a development since that. Actually, we have 159 specialists in sexological counseling. Astrid said a little bit about the system because it's Nordic. And but a lot of them are working in private clinics, or they are just putting the sexology education into their care as physicians, nurses, physiotherapists, psychologists, and others. But we are really, really growing, and also in this area of oncosexology. Despite this growth, what we see is that it's really random. We have guidelines of cervical cancer, vulvar cancer, prostate cancer, and breast cancer. It's recommended that people see a sexologist or are being asked about their sexual health. But it's just something, it's just a recommendation. So it's not like everybody, you have to do this. So we need some firmer guidelines to help us through this, to put it into the system. But the legacy is actually from Espen Esteparelli Benestad and Elsa Almos, who started in 2001 an education, further education, which almost everybody in Norway tried to do. Not everybody is able to, because it starts every second year. And I'm also working in this education. And 2 years ago, we had 600 hires for around 45 places. So it's really, really popular, and it's really, we can really have good students now. So this education is what leads to the next accreditation. And for, I think, about 20 years, we have been the main lecturer on oncosexology. So we put in really, really firm, good research, and we talk a lot about oncosexology during the trajectory. And I think that's also because a lot of the students who have been taking this course, who leads this authorization, are oncology nurses. So they're really interested in it. And of course, they know by patients that patient wants to have this education. I thought what you said, Astrid, about the two-way taboo. I am writing about it in my first article as well. And I think I have been having a lot of teaching at the hospital lately. And I have this headache, how to implement sexuality when efficiency is killing us. And I really love it because you have to make it go like a low resource demanding. You have to do it low resource demanding because there is a lot of demands from all healthcare providers. So we should just come with this grade. But also we have this small education.
Yeah, she disconnected. I can't do anything. Others are still moving.
We do have an university now that also started, they started last year, to have 7 courses that they can put together as you want as a student to a master module, and 5 of them include oncosexology. So they have been doing a good work on that. And there's 4 other universities who do something in sexology or gender, and sometimes, especially in psychology, oncosexology are implemented. It's not a course on its own. In 2017 in Norway, we had this big, it's called Talk About It, Let's Talk About It. We had this big plan on implementing sexuality in all healthcare professions. And last year, colleagues at Oslo Met they tried to see what have we been doing, and what they concluded that we are still not there, I'm afraid, because we also need to put it in the basic education of nurses and physiotherapists and doctors, and we have not been able to. On my own institute, I teach nurses in sexology, also oncosexology, and I think it's like 6 or 8 hours in a 3-year period. So, and the students are really think they don't get enough of it. So we're not there yet, but in my own university we put it in all advanced and further education, and I have been teaching oncosexology and palliative care education. So things are going on, and regarding patient information, there is a lot in Norway. I'm not able to find all of it, so this is just a couple of examples. The Norwegian Sexology Society has made educational films, and 2 of them are directly on oncosexology. They use examples on how the doctors can use it. And we also have for patients, this is gynecology, e-digital health care, and one module is on sexual health. And we have this center in the west of Norway who has been working mainly on oncosexology, and they have been made like brochures for healthcare professionals, for partners, for all kinds of cancers. They've been doing a really good job and have good funding as well. So these are really nice. They use patients as examples, and that's why I think they reach out as well. In the National Cancer Society, we also have they have been working on the same thing. So it's really easy. This is one of the sites that pops up really easy. It says cancer and sexuality, and then you can go into themes, and if you're youth or if you're into technical aids and that. Also in the national healthcare, we have added pages. This is like the main thing that you go into in Norway, and also Oslo Met, the university, have made a free digital e-learning course for sexual aids for healthcare providers. So there is a lot going on, and these are for professionals. And the main library where they also add research that have been doing in this area. According to research, there is a long list, as I said, and these are only Astrid Liavåg and Sofie Fosso are pioneers on gynecology and prostate cancer, and they now have PhD candidates, and they are unfortunately they are getting retired, but the legacy is still going on. And when I did this work, and it can of course be from my point of view as well, there is a lot on gynecology. So I was so happy to see that as a PhD candidate now that do something on head and neck cancer and sexuality. And also we have had colleagues at Oslo Met that go into the palliative care. I used to work in palliative care for 5 years, so I'm really fond of this group, and I love this title, To Live Until You Die. So, and Ragnhild Sekse, I have to mention her because she's big capacity. She actually did her PhD on gynecological cancer first, and then she took her sexology education based on what she saw was needed. So I think she is really, she's going to do this until she retires, she says. So she has a lot of publications on different gynecology, cancer, and others. And there's a whole research group on breast cancer in the middle of Norway. So all these people are working on the same population on different groups, and it's on sexual health. So things are really growing in Norway. So this is my small contribution. This is my first article. It will come out next week. I also do some chronics, and I did research Grand Prix with this on presentation just to get out the message. And I'm going to NAX in September and present this, and yeah, I talk about it wherever I can, so I'll try to contribute, but it's quite modest to this stage. And I also want to just have the opportunity to thank Bente Tre, who passed away earlier this year, for her contribution also to this subject, because she still also had cancer, and she did a good chronic in the Norwegian Cancer Society, where she took her own history of cancer and how she was met according to sexuality. So there's a lot of contributors, and her legacy is also still living. Okay, so that's the situation of Norway. So don't you think we're getting there, boys? We are getting better. But we need to collect us, and we need to start working better together.
Thank you very much. I think it's really extremely interesting what's going on in Europe, and I just had the idea that we actually should put it together in a small publication. Just these people would be so everybody would be interested, and we should think about it. Maybe could be one of our future plans when we discuss this later. There is a question. Maybe Faisal. Yeah, Faisal. Maybe you come here and ask your question.
Thank you, Anita, very much. You have presented a really excellent, diverse type of work happening in Norway. But then in one slide, you mentioned there was some randomness in terms of accompanying survivors in the trajectory of the cancer treatment and stuff. So do you think you might need some kind of like central organization or facilitation among all these groups? And with all these like really impressive work and activities, why do you think it's still random and some of the survivors might be left alone or not engaged in the talk about maintaining and promoting their sexual health and sexual function? Thank you.
I think it's an important question. Thank you, Faisal, because what I see, I also did interviews with nurses, so we know about all these barriers, but what they have, but also we need someone to decide that they should do it. Because if nurses or doctors should do it, they're really addicted to, they are into their work, they want to do what's right for the patients. So they need time to do it, and they need someone to decide it. So we need some national, that's what we were hoping about with the publications talk about it, that someone should decide that you have to do this, you can't decide it. Because I am kind of shocked when I see patients who have been into cancer care for 5 or 6 years, and they come to my office and they say, no one has ever mentioned that we have a sexologist, and no one has ever mentioned that something happened. So someone needs to decide it, and that's why I don't like, actually the guidelines are okay, but it's just like a recommendation.
Do you have? Do you happen to have some sort of a patient support group or survivor support group that might increase demand or increase awareness around engagement?
Yes, especially the large groups on prostate cancer and breast cancer are really working into this, and they have just started doing their own work. They have their own sexologists, and all these groups have. You can ask the sexologists for free, webinars, and so they have kind of taken their responsibility for this, and that's good. But in Norway, we have this pride on this public healthcare, and we should have it implemented as well. And the director at my hospital, she came to my office and said she was happy that I had a position at the hospital. So I think that's also that she can say that we should have sexologists in the public care as well. So I think we need someone who with a little bit more of muscles and we have to fight, of course.
Thank you very much. I think you have enough muscles yourself. Use them.
Yes, I will. Thank you.
Faisal is right. So thank you very much, Anita Paulsen. I think we make a 5 minutes break, if that is possible, and because we are a little bit late with time, and then we continue. 1 second. Yes, and then we continue with the talk of Pierre Bondi. Okay, so just a 5 minutes break. Okay. So, dear Pierre Bondil, we are looking forward very much to your talk.
You're muted, sorry.
Sorry. Hello.
Pleasure to see you.
Yeah, it's nice to see you, and we're looking forward very much to your talk. So maybe you start with your presentation, and please also introduce yourself.
Recording in progress.
Thanks for this kind invitation. I will talk about the lesson when we set up cancer and sexuality team, 20 years of experience. I'm Roger Oncology Sexology, the president of the main French Sexology Association, TIUS, and Professor Wig is the urinary oncology. He's also we are the coordinator of the French Association of Supportive Care of Oncology, Cancer, Sexuality, Fertility Expert Group, and is also the coordinator for the French Urological Association of the Oncology and Sexual Medicine Committee. We present you the successive programs that we observed during the period of setting up from 25 to present day. During the lesson and recognize the best action levels, we have distinguished 4 different phases: inventory, operative, reinforcement and expansion, and consolidation. The main point during the inventory phase was the constatation of main breaks for homosexuality setting up. There is a major gaps for organization offer and knowledge skill. Main difficulty of communication and dialogue, widely shared by patient couples and healthcare professionals, mainly due to taboos, myths, and false representation. So the first mandatory step was to sensitize and to get all healthcare providers on sexual health and intimate life, to know what we are talking about, very important problem, and to know how to do. That means needs to have a clinical, practical background. Cancer and sexuality is in the world of oncology world and not in the sexual world. It's in the world of supportive care. For this reason, we distinguish between oncofertility and oncopsychology as for oncopediatry, geriatry, plastic, and genetic. So the semantics is very important because we are in the domain of cancer. The natural place of sexuality is in the domain of the cancer supportive care. And very important point, they never talk about sex, but always on sexual health and intimate and sexual life. It's a major key point for the education and training and important of the healthcare profession. The negative points that was that the healthcare professional, mainly the physician, was to consider too often the sexuality as not serious and was not a priority. The resistance was multifactorial. Healthcare professionals are mainly reactive and too partitioned off, and the reality is that homosexuality was mainly based on engagement of few motivated persons 20 years ago. The positive points that there was a real and high awareness to the sexual dimension, added value of our successive healthcare professional survey for more than 1,000 of people, and we also note the interest of the Association of Patients. So, to obtain both support and approval of healthcare provider and institution, it's a mandatory step, but is not sufficient. The second phase, operative, that was that neither over nor underestimated the sexual intimate care demand. Sexual intimate life varies according to many factors explaining that needs and demands are inconstant, heterogeneous, and changing with time. And dramatically, if proactively asked, almost all patients and couples are interested by information, including the older ones. 1/3 are not interested by a treatment. 1/3 is interested by a treatment if it is simple, and 1/3 are in demand, even if the treatment is more complex. And this is true for all the different categories of the population in our survey. So, to highlight the importance of the unmet sexual intimate needs, it's a big demand of the Association of Patients. We must remember also that this usual sexual morbidity to a iatrogenic hepatitis measure. The mechanisms are different. The particularities are that the negative impact are very often sudden, chronic, and multifactorial. The most deleterious treatments are pelvic surgery and radiotherapy, chemotherapy, touch-therapy, hormonal therapy, and mutilating detrimental sequelae for the patient. So to inform and to be informed about side effects and patient-reported scope, it's a patient right and healthcare provider duty. In France, as in Europe and other countries, cancer survivors are a booming population. Last year, there was 3.8 million survivors. That's potentially 5 million people concerned with a partner. That means 1 out of 7 French adults. Second point, cancer survivors are at least double the individual likelihood of poor health, disability, and lower well-being. So there is a need for prolonged follow-up. So you have 5 million. You have in France 10,000 health professionals that know sexual health. You have 10,000 and 5 million. There is a problem. So the practical consequence is the first sexological response is one among numerous one. 3 obvious priorities to avoid to send immediately to the sexologist, to correct strong inequities of care access, to organize the cooperation for the continuum. Sexual problem is under the responsibility and the competence of the large majority, i.e. the first line health professional, that means the primary care. So it's complex to organize, to structure, to coordinate the sexual pathway with 3 input modes. You see, we did it in 2012. There is a patient and partner. Of course, they can go to the physician, to the HCP, and to the oncology specialist, but also they can go to the supportive care, or they go to the patient association. The response is public or private, city or hospital. There is a multiform toolbox and multidisciplinary, and you see among the different response, sexology is only one of the response. So it is not mandatory to send to the sexology if there is a sexual problem. We did the first worldwide dedicated guideline at our knowledge because it was transversal, all patient, all cancer, all treatment, And to see, you can see what guideline for who, which cancer, who is involved, when to take care, when to see, what checklist. This was the first one, and after we do for the breast cancer with chemotherapy or monotherapy with fertility, for the teenager and young adults, and for males. These referentials are available directly on AFSOS.org. And another very important point is that the strong impact of the attitude, exemplarity, involvement of physicians, even if they are not interested by sexology, it is their duty, their responsibility to set the supportive care in their team and in their institution. We identify two new facilitators, the partner and the patient association that we are working more and more to optimize the visibility of sexual offer within the supportive care, needs to build up and diffusing regional directory of sexual health competence, regularly updated, it's a mandatory key point, to develop multi-target information by a different way, and to develop offer of initial and continuing training for all involved health professionals. Problem, c'est que tu vois, guidelines for health professionals is a necessary step for improving the care quality, but it's not sufficient because there must be also a diffusion and implementation strategy of this guideline. For instance, for the in 2010, we make a specific tools, a specific program with awareness training for all health professionals, 2 hours solicitation. 4 hours for motivation training for nurses that work, for instance, in chemotherapy service or surgery service, gynecology service, and 2 days for expecting training. We make a checklist for sexual health and intimacy assessment with different domains, with sexual health, sexual act, life project, environment, and quality of life. This target was all health care professional and is a useful and also educational clinical tool. We created also a specific congress regularly every year, and now it was in 2012, and we are now in the last one was in Martinique, the Caribbean. The next one will be in Paris. And important point, we have an official institutional operation by INCA. INCA is specific in France, is a National Institute of Cancer. It's a very strong and very powerful institute that controls all cancer. And it's fine others that there was a lack of information of patient and lack of visibility of the offer. So they call for an application for a guideline and a recommendation on preservation of health sexual for the patient we were and we presented, I was a reporter with the AFSOS, the French Association for Supportive Care. And in 27, supportive care is mandatory treatment of cancer in France. And if you have not a service and response in supportive care, you have not a certification, you are not accredited to do cancer. And within the 9 only mandatory supportive care, you have the treatment of sexuality. This is the guideline. There is synthesis that is 30 page and the thesaurus that is about 250. I show you only 2, but there is more than 40 recommendations. It is recommended to integrate the preservation of sexual and intimate life through the course of care and post-natal supportive care, grade B, to analyze the sexual or intimate life from the patient point of view, patient to evolve is a grade C. There is different official practical tools for healthcare providers. This is for all, maybe the GP and specialists, it's more for GP, and this is how to organize the supportive care. There is a development of a dedicated digital platform for support care, including sexual health intimated in different regions of France. This is in my region, in the Lyon, in the south, in the Alps, and you can see the directory to have the competence in cancer, life, and sexual health. Also, as there is a huge demand and few professionals, we recommended to have an adapted, gradual, and step supportive care approach, parallelly with Australian, with all professionals are involved in support immediate information, many more care, and afterward we did the same thing with the primary health professional, secondary, and the expert, and we differentiate the oncosexuality from the oncosexology. For us, oncosexuality is for all the people, and oncosexology are only for the level 2 and the level 3. You can find it in Google referential. We use the same progressive strategy for training and education for the healthcare professional, to formation of first level, second level, and the third level is a special postgraduate university diploma in counter and sexuality. Dr. Troussier will present just after, and it was good. It is the first worldwide in 7 years ago, and now there is 8 universities in France doing this diploma. To conclude, you can use, if you want, this relevant strategy for setting up oncosexuality. To become an actor in sexual health and quality of life is an individual but also a collective challenge. There is 5 action axes for responding to population, patient, and care provider needs: to organize, inform, training, therapeutic. One imperative: progressive and multi-target process, i.e. transversal, multi- and transdisciplinary and cooperative work in time. The key word is supportive care and not sexuality. And the current challenge is to privilege a holistic and personalized centered approach. Thank you.
Thank you, Pierre.
This is yours?
This. Okay.
Okay, sorry.
Are there any questions concerning the talk of presentation of Pierre?
Very impressive.
Very impressive, and thank you very much for the great presentation. And now we go to Thierry Troussier from France too. Please present yourself.
Okay. A short presentation about diploma of oncosexuality. This. Okay. Thank you. Yes, this oncosexuality, sexology, inter-university diploma, the head of this diploma is Eric Wig. He's a professor of urologist and andrologist. Pierre Bondil present him in our slide. Yes, what is a learning objective of this diploma? To respond optimally to the need of cancer patients and survivors in order to restore their sexual health in all age groups, to be able to assess, diagnose, and optimally manage sexual dysfunction or sexual behavior disorders in patients treated for cancer through the personalized care pathway, whatever the patient's gender and tumor type. Acquire the know-how and interprofessional skills needed to provide information, education, and advice in the field of oncosexuality in the line with WHO recommendation. Be able to implement preventive measures to reduce the impact of cancer treatment on sexuality in line with ARSOS guideline. The public is for initial training, a third cycle of medical study in oncology, gynecology, and urology, or other oncology-related activities. And for the continuing training, only medical specialists like this, general practitioner employed by a cancer center or other establishment, professionals working in sexology, sexual therapy, counseling, etc., and clinical psychologist practicing, and nurse, especially in oncology services. Methods: weekly e-learning courses in the form of a slideshow, possibility and PDF, and possibility supplemented by video or audio courses. This teaching will be in line with the free ARSOS guideline on cancer, sexuality, and intimacy. Second, face-to-face, 3 days a year, focusing on practice analysis, clinical case, and questions from patient forums. And compulsory attendance at the Rencontre Cancer, Sexuality, and Fertility, like Pierre in his slideshow. In total is 116 hours in 2 years. The program, a chart, general oncology, the main types and of cancer and their treatment, genital, mortality, and age. Fundamental knowledge about normal sexuality, sexology consultation and diagnostic, general information of sexual dysfunction, organic aspect of oncosexual pathology, sexual dysfunction in couples, psychopathology, and sexuality. The second year is 80 hours. Is a management of sexual dysfunction in the context of cancer. This is example only concept of health and sexual health, sex education, sexuology counseling, model for inquiry, how do you begin your sexuality when faced with cancer, etc. My last slide is a validation. The validation for the first year is a writing exam, attends at a face-to-face session. And the second is a national writing exam to end of the year, attends a face-to-face session, end of year dissertation and title and works. Thank you. This you have email of eric.hugh@yahoo.fr is the head of this diploma.
Thank you.
Thank you.
Thank you, Thierry. I find that really excellent, this program. May I ask you if you just started it or if you will start it next year, or if you have already experience with it?
Yeah. Is 2 years, and he starts 1 and 2 years after only in the 8 university, and is bring together for this diploma. And we have, for example, in our university, there were 8 students, and different universities, around a total 30 or 40 students.
Could you stop
Both
sharing?
2 years.
Stop sharing so they can see.
Pierre. Okay. Excuse me. Pierre, do you...
Thierry, so do you have any feedback from those who graduated and are working?
Feedback about?
The cohort that graduated?
Yes.
You have 40 people who finished?
Yes, there were a free promotion.
Okay.
I think, Pierre.
You have
There were 3 or 4 promotion now.
I don't remember, but it begins in 2016.
16,
So
yes.
now I think it must be
I think
the fourth one.
yes, now.
And you have feedback on their work and any feedback they're telling you they're doing fine, they are filling the gap.
In your university, Pierre, you have a feedback in Savoy?
Oh, I noticed it in academic is mainly Professor Eric Green, and that is the leader in this topic.
Okay.
I am most involved in the problem of the training, of the continuing training for all else, because it concerns this level 3 concern few people. It's increasing regularly, but also we are very careful to increase the knowledge of all the people, because as you say, there is in France, and I suppose in every country, there is a lot of people who are on demand, and the healthcare professionals are only too little number. So it's very important that every primary healthcare can respond, can inform, because a lot of problems are not complicated, are very easy in general. People needs reassurance, and the simple information is almost half of the problem. And after, you have problems who are more complicated, and as we do in cancer, in cardiology or in gynecology, you send to the specialist. So we must, for this reason, at the beginning we saw oncosexuology, and after we changed, because oncosexuology is only at the top for the response, therapeutic response, and oncosexuology is important for organization, of course. But the problem is to correct the important inequality of access and quality, and that concerns all the primary health professionals.
Thank you. Okay. Yeah. Thank you, Pierre.
Thank you, Pierre. Can I ask a question for both of you, but also to Mr. Bodil? Because your talk, you've told us so much about the development of homosexuality in your country, and I was wondering what makes it that in France all these developments have made it through. Is it just one person already battling for 20 years, or is it certain legislations or certain movements that make it more possible for the homosexuality to develop the way it has in France?
It's so lucky, because honestly, 20 years ago, if somebody told now to take supportive care and to take care of sexual problems is mandatory in the cancer continuum, I said this is impossible. But we have the chance in France that we have a very strong Institut National of Cancer, and also the main chance I see is to very soon to say to localize in the supportive care, because for me the best report is supportive care, because when you say supportive care, everyone knows where is located sexual, and for this reason there is sexual problem, but there is also psychological suffering, there is a problem of physical, like I said. There is 9 supportive cares that are mandatory in France, and for me, when we say talk about sexuality, I say yes, but this is within the supportive care. So you must first think through supportive care, and after you organize with, for example, palliative, the pain, it's very important, and all these problems are linked. you have chronic pain, you have bad sexual life, mandatory, you know. And for this reason, it's important to have this holistic view. And one of the reasons also is good knowledge. As I am in supportive care and in sexology, I have a transversal and horizontal vision. But now the problem, I am also a urologist and I operated cancer prostate. But I look to my colleagues and I know that there are cancer surgery, you know, and there are more technical than the more vertical approach than horizontal approach. And for me, this is a very problem now. That we must have a view like a GP, but many of the specialists forget this GP vision, you know, the general vision, and humanistic, etc. and so on.
Yeah. Okay, thank you. So we all should get more horizontal and less vertical.
So really impressive, and so we can learn a lot from France, and we will certainly do. And I'll welcome now our next speaker, Inge Peter from Italy.
Stefano
Hi, good morning, everyone. No, it will be Stefano Elaturi.
Okay, so sorry, I thought he will be behind you. So Stefano, could you introduce yourself, please, and start your presentation? Sorry, I had it different on the program.
No, it's all fine. No problem.
Hi, thanks a lot to all for the invitation to present the situation in Italy regarding oncosexology. So, I, as suggested in the proposal that you made, I tried to present in these 15 minutes all the guidelines and the practical aspect that we have regarding oncosexology in Italy. And I have to say that what I'm going to present is that we have probably a different approach regarding the guidelines and unfortunately what we have in the practical aspect. And it is something that in Italy is typical of the sexological aspect. And I will better explain later how is the situation of sexologists in Italy. Let's start with the guidelines. We have a lot of different medical societies in Italy that take care of oncology, and here I present all the more recent guidelines that we have that take care of sexual health. You can see that we have, for example, this year was updated a guideline by the Italian Association of Medical Oncology in partnership with the Italian Society of Palliative Care and the Italian Society of Psycho-Oncology, where they talk about the management of various cancers, including also recommendation on addressing sexual health issues during and after cancer treatments. And also they talk about the importance of being proactive in the assessment of sexual health and also on the impact of sexual problem on well-being. So as you can see, the guidelines are specific, and we have also specific different guidelines for example, the rectum and anum neoplasm, and also regarding the blood cancer neoplasm, and regarding also the testis cancer. This one, from my point of view, is the one that take care mostly of the oncosexology, because it also talks about the perception of masculinity and the importance of the, from this point of view, of this. So, as you can see from the guidelines, of course, we could also proceed, but we have a good starting point. What is the problem is just when we talk about care, we have just some small examples of oncosexology taken care by the health system. We know that in Italy the healthcare system is public, but what is good is that, of course, we have what is perceived as necessary that is passed by the government, but in this point of the situation, oncosexology is not perceived as something necessary, so we don't have so many sexologists in the healthcare system, and this is, as I anticipated before, is something that is not just specific to oncosexology, but is specific of sexology in general. So usually Italian people, when they have to take care of sexuality, they have to pay by their own and refer to the private sector. So I found some little examples, like for example in one region that is called Basilicata, that is in the south of Italy. They tried to organize some free oncosexology sessions, but they proposed just for one day in 2023, and they had a lot of different requests, so they tried, of course, to integrate this as part of the normative system, but they're still working on it. Another onlocus in Novara, in the north of Italy, tried to do it some years ago, in 2020 and 2021, but they organized just some days of talking about oncosexology with different specialists. And this is, again, connected with what I said before, that the sexologist is not usually part of the normal staff that work in the hospital, usually in Italy. So, of course, nowadays what usually happens is that some patients will opt for private healthcare facilities or specialists that offer oncosexological care. And of course, in these cases, the cost of this care may be paid out of pocket by the patients or also covered by private health insurance plans. And of course, the coverage and the reimbursement options can vary based on the specific insurance policy. So, of course, we cannot offer the same rights to all the different patients when taking care of these. Again, what I wanted to stress here is that, unfortunately, in Italy we have a big situation of disparity, because in our country the health is governed by the regions, so unfortunately healthcare policies and also financing mechanisms can really vary across different regions in Italy. So what I presented before is what, for example, was done in 2 different regions, and we can find that there are healthcare disparities between different patients living in the different regions. Of course, what also happens is that local healthcare authorities may also have their own guidelines and regulation regarding the financing of oncosexological care, and of course it is advisable to consult the specific regulation and coverage provisions in the different regions. So what happens till today is that Italian people go to different regions in order to have better services when they perceive that in their region we do not have the system that is good for them. And of course, what happens is that Lombardy, where there is Milan, and Latium, where there is Rome, are the most trafficked hospitals, and usually there are the most better services also regarding oncosexology. When arriving to oncosexological education, unfortunately, we do not have a specific certified educational programs in oncosexology in Italy that are widely recognized or established. Of course, we know that oncosexology is an emerging field that addresses the sexual needs of cancer patients, but the availability of specialized educational programs in this area may be limited. Unfortunately, again, this is something that is diffused for sexology in general, where we have just a private possibility of education in Italy, because still today the sexologist is not a figure that is recognized, so the psychologists, the physicians and the sexual health specialists that to study sexology should do it from a private point of view. And of course, working in the oncosexology field may require additional training courses or certifications in areas that are related to oncosexology in the specific. What we tried to organize, I'm part of the Institute of Clinical Sexology of Rome, and for example, in 2021, we organized an online course specific in oncosexology, aiming to address the need for an adequate training for all healthcare professionals involved in the care of cancer patients. When we tried to organize the course, we had the aim to provide all the scientific knowledge and also the practical skills in order to address sexual health consultation, following a biopsychosocial approach, and also the most effective interventions and support models. So we had a lot of people that attended the course, and I hope that it was useful in order to increase the possibility of this knowledge in Italy. Regarding the information to the patient, again, we have also a lot of associations that work with the patients. For example, one of the most important associations that we have is this one that is called IMAC, the Italian Association of Cancer Patients and Friends, and I created a series that caters about 40 booklets on individual neoplasms, effects, treatment, and also advice on how to live with the disease and feel better. These booklets are a valuable information tool that thanks also to the concession of Macmillan Cancer Supports, provides free of charge to the patients and to the family. What they have done is that, for example, this is one that is very interesting, is about sexuality on person with cancer. As you can see, we are in the 4th edition of this booklet that has been published last year, and they try, of course, to take care of all the important aspects regarding sexual functioning and the impact that both physically but also psychologically can have as a result of cancer, but also of the treatment. Another nice resource that we have in Italy is the one produced by the Italian Association of Cancer Research, the AIRC, that created a series of articles, and of course the translation of the booklet from the ESMN guidelines that can help, for example, for this specific cancer. So I finish my presentation talking about the research that is still ongoing in Italy. So to my best knowledge, in recent years, research in Italy has explored various aspects of the correlation between sexology and oncology. Some common areas of investigation include, of course, sexual dysfunction and cancer, quality of life and sexual health, and of course the psychosexual support and counseling. some of the most recent articles that have been produced by Italian researchers. And for example, this one was published by our own journal, the Journal of Clinical Sexology, that is published in Italian, so that we can increase also the diffusion between people that do not talk in English. Okay, so I finished my presentation. Before ending, I wanted to invite you all to come to the congress that we are organizing in Antalya with the World Association for Sexual Health. I want to remember that the next week we'll have the deadline of the abstracts and also the reduced registration, so it will be really nice to have an oncosexology panel, because we still have time to present symposia, so I'm part of the scientific committee and will be happy to include also this aspect. And also next year we will have the EFS Congress in Bologna, in Italy. So again, I hope to see a lot of people of you to come also in Italy. Thanks again. I leave all my contacts so that if you want to have some information and everything, I'm here. Thank you.
Thank you, Stefano, and also thank you for your invitation. It might be interesting for some of us. And are there any questions concerning the presentation? Faisal?
Yes.
Yes. Just a second.
Thank you, Stefano. Definitely you will see me in Antalya. We will be very busy working together. Stefano, this is very impressive also, very much like France, Norway, and I think all the presentations really impressive. Do you think if we have to make things more efficient, like at the intersection of the gynecologist and oncologist and andrologist, is there some kind of ownership where like some society should be overseeing, because you mentioned the Italian Association of Radiology, Italian Association of Clinical Sexology. So are there many separate things happening differently in different regions? You mentioned something in the southern of Italy, like free seminars, webinars and stuff. Are there any effort for support from the public health sector later on? Or are there any national effort to bring this to one place and make like national guidelines that will advocate with the government at the same time with the physicians and other providers? Thank you.
Yes, it would be interesting to have, of course, shared guidelines. So what I presented are shared guidelines, but mainly from Cancer Association. For example, this afternoon I will go to the Italian Congress of the Andrology Association, and in the program we don't have anything about oncosexology. So it is something that is still difficult to arrange in the different associations, and I think that probably we that work in the international societies should press to focalize in the different societies to do a shared guideline.
Yeah, I don't think, if you agree with me or not, I think it should be initiated by sexual health people. Because if you see the oncologist, all the studies will tell us oncologists don't initiate discussion, they don't know how to talk about it. Women never ask about this, or men. So I think it should be initiated by people who own it, like the sexual health practitioners in different domains, who gonna initiate this and then go around to different specialties and coordinate with them across this? Because I find it very strange. It's coming from oncologists or coming from, let's say, cardiologists. They're not trained to talk about it.
Yes, thank you.
Yeah, thank you.
We'll do our best.
Thank you, Mr. Terry. To raise a problem, a very important problem of the finance problem. I think for this reason, in France, we are very careful about, as in other countries, obviously, of the problem of the inequality of care access, but also of financial aspect. And for homosexuality, it's a real problem. And there is two different aspects. And we work with the ANCA, the National Institute of Cancer, about the out-of-pocket. In France, we say the reste à charge, what the patient have to pay. Because, for instance, in France, PD5 are not reimbursed, but the intracavernous injection are reimbursed. So there is very difference of reimbursements according to the treatment. Psychology therapy may be reimbursed 1 or 2 times. So I think it will be very interesting for us and for our patients and to develop the homosexuality is to take advantage of this working group to see what happens in the different countries of France, of Europe, about the reimbursement, how it is in Italy, in Spain, in Norway, in England, in Germany, and so on. No? Because there is very difference. And if we there is, I think, many differences, and if we show this to the politic, I think that will change. For this reason, also in France, I work a lot since the beginning with the patient association, because the patient association is a lobby very important, to change the thing. And so we are doing this. But I think we are a group, an interesting group, and we can do everyone in our own country what happened about the financial aspect. And this is for the patient, but also the aspect for, I take my cap of president of the Sexology Association, how it is reimbursement for the health professional, because in France, as in other countries also, the sexologist, sexotherapists has problem to be reimbursed. And so they don't do full time, they do partial time, owing to this reason. So I think we must see these two problems for the patient, but also for the health professional, because if the health professionals are better covered than the patient, I think that the response will be improved for cancer, but also for all the sexual problems.
Would it be a good idea for this group, for example, to think about creating own guidelines for Europe for oncosexuology? I think that could be a very good first step. We could discuss it later in the latest session, and we could include. We would of course include you would and whoever is interested. That could be a very interesting first topic. And I also spoke with Astrid in the past. We thought that it would be also maybe the very first step could be for us to make a publication from what's going on from your presentations. So it's really an interesting overview. And again, we would include Austria and Netherlands and whoever is interested to show the situation in his own country. That would be a very interesting first publication, so that we start first steps as a group.
And maybe a short also, I think it will be very useful, because we would remember this, which we wanted to use the French guidelines to see if it is available for other countries.
Of course.
Because it was a very huge work during 2 years.
Excellent.
And
Excellent.
Everyone can take it and say it's good, it's not good.
Yeah. Excellent.
It will be European based on this.
Yeah. But how interesting to get an overview about the European situation, and I think that's a good plan. So now, Inge Peters, I think it's your turn. Is that right?
No. I was
erroneously put on the program.
Sorry, I did not understand that. Ilenia made the program, and I asked because she asked me to overtake her position as she was not well in these days, or is not well. Just a moment, let me have a look.
No, it's fine. I'm from the Netherlands, and I'm here in Italy for a year and a half. So
Sorry. Now the next one is Ana Luisa. Ana Luisa Gomez. Please start. Please present yourself and start your presentation.
Thank you, Marianne. Good morning, everyone. I hope you can all see me and hear me well. My name is Ana Gomes. I'm a clinical psychologist and also sex therapist. And at the moment, I'm also working as a researcher at the Center of Psychology at the University of Porto. So my main focus of research has been related to sexual health in patients with cancer, and I have been working very hard in developing and implementing evidence-based programs and intervention programs for these patients. So thank you for inviting me for being here today. The slides that I will be presenting, they were carefully prepared with Bruno Pereira, who unfortunately is not able to attend this meeting today, but he asked me to express all his appreciation and send his regards to all the colleagues of this group. So we try to follow the inventory and the template that you provide us, and to organize some slides to give you an overview of the status of the homosexuality practice in Portugal. And regarding the guidelines, we struggle in finding information regarding this. And thank you, Marianne, for your excellent suggestion for this group to organize and try to prepare some international guidelines that we can use in our countries, because it is very important to have clinical orientations and to create this awareness regarding the importance of addressing sexual health with patients with cancer. So in Portugal, we only have at this moment a very recent consensus paper provided by the Oncoradiotherapy Working Group of the Portuguese Oncology Nursing Association, which prepared this very nice document highlighting the importance in addressing sexual health in patients with cancer and how nurses can refer all these patients to specialists, and also summarize some clinical orientations and practical suggestions to nurses to address and to approach this topic of sexual health with patients with cancer. We also have a joint publication between the Portuguese Society of Oncology and the Portuguese Society of Andrology, but specifically addressing the thematic of infertility in patients with cancer, and provide some recommendations regarding the preservation of reproductive potential in these patients, which is also a very important topic regarding sexual health when we talk about patients with cancer. Regarding the provision of homosexuality in Portugal, well, we have, it's very difficult to estimate the number of professionals that are working in the field, because as a multidisciplinary discipline and the great majority of and differences in professional context that these professionals are working, it's difficult to have this estimation, but we are trying to, in a group that I'm coordinating under the Portuguese Society of Clinical Sexology, we have this Sexology committee that is leading by me, and we are trying exactly to do this, to give a good perspective of how many healthcare providers are working in the field, what training do they have, what resources do they use. So it is very important for us to have a more formal information and data regarding these professionals that are acting in the field, working in the field. We anticipate that there are not that many as we would like to, but I think, and for informal information that we are having, we have some professionals that are trying to organize themselves and some clinical services trying to organize themselves in order to give a better provision of these services to the patient. Regarding specialized hospitals, we have the Portuguese Institute of Oncology, which is a public hospital that is working and based in different regions and cities in Portugal. I'm sure you have all heard about the Oncosexology multidisciplinary group that is a specific group that is organized and is actually working in a very well organized and integrated way regarding the provision of oncosexology care to their patients. Also in Lisbon we have an oncosexology clinic and working under this hospital, and we know that in Porto there is a plan to organize such a group to provide this specialized service to the patients that are being treated for cancer in these specific hospitals. Then we have general hospitals, private patient associations that they have, for example, services and specific consultations regarding psycho-oncology, but not specifically oncosexology. In fact, oncosexology is not a type of care that our healthcare providers working in the hospitals are very familiar with. That they, as I think is consistent what we have been hearing in previous presentations, most of the providers, they don't feel comfortable, they feel that they don't have the time or the resources to address this specific topic of sexuality with their patients. So there is a lot of work to be done there in Portugal. So regarding to patient referral, well, we need definitely to establish a network to referral patients. The Oncosexology group in IPO Coimbra has recently, and this is very interesting and is of course a result of the hard work of this group, they are starting to receive patients from other hospitals or for other professionals that know the service and try to refer patients there to get some kind of provision regarding sexual health care, addressing the specific needs of these patients. In general, what we see in those hospitals or services that treat patients with cancer is that when this topic is addressed and when the professional wants to refer the patient, what they probably do is to refer them for a specific psychologist or a colleague they know that have a specialization in sexual medicine, for example, but not specifically on oncosexology, or refer patients to the private hospitals or to the clinical practice. What we sure know is that most patients that are being treated for cancer in Portugal, they don't have access to specialized sexual health care. And this is the concern because we know that the numbers, the incidence of cancer in Portugal is also rising, as well as the survivorship. So we know that all the treatments equally, the impact, the emotional, the physical impact of cancer and the treatments in the patient impacts greatly their well-being, quality of life, and has very specific negative effects in overall dimensions of a patient and family and couples well-being, and it is very important to address this topic. But we know that there are a number of barriers. They are very well identified in the literature and in our experience. So we clearly need to have and to organize ourselves to create awareness regarding these needs in order that we can provide more specific care, healthcare for these patients. The funding, well, in this service of the group in IPO Coimbra, as it is a public hospital, all the consultations, they are integrated in the service that the hospital provides. But patients support all the costs regarding the treatments. Occasionally, and this is as this has the merit of the director of this service, Dr. Ricardo Godinho, they have created this partnership with a patient association, which is the Portuguese League Against Cancer in Portugal, and in case of financial impossibility, this patient association may help and mobilize some fundings to help the patient to pay for all these expenses. In an education level, well, I would say that we have very good programs regarding sexology and regarding human sexology. We have at least 2 master programs working, 1 doctoral program at University of Porto, post-graduation in human sexuality, but not a specific training or education course regarding oncosexology. We know that in these programs, the topic of sexual health is addressed, sexual health in patients with cancer is addressed, but most of the times only with a very low number of hours in those courses. Also, there are some certified courses on psycho-oncology or clinical psychology. This is the same scenario. So this is on a private way of getting education, but we have several associations providing these certified courses, and in the scope of those courses, there are oncosexology is addressed. Specifically in our Portuguese Society of Clinical Sexology, we are restructuring the program, the formative program. We are planning to have next year a new course regarding clinical sexology training, and we are planning to include oncosexology training as well. We have, and lucky of us, we have several scientific events, several professional are some national congresses on specifically on oncosexology. We had one in 2022 organized by the oncosexology group of Coimbra. We will have one next year, and then we have a number of webinars, workshops, some of them organized by Patients Association, which is very important to create awareness within the general population. And actually that's an important message that I think it is important to have it clear here. It is important to have information and to create this awareness of the need of specialized care in oncosexology for patients, for professionals, but we also need to work very closely and within the general population, the community, We need to create also this awareness and to make people sure that addressing sexual health in overall in overall situations is a very important topic specific for patients specialized with cancer. And these are initiatives that actually work very well in Portugal. We had recently one open session in the scope of a financed project that we had at our faculty on prostate cancer and sexual health. And the way that we find to deliver the information and to share, to disseminate, and to translate our research into the community is to create this open session where we invited a number of professionals, of course, but a number of stakeholders and have a great involvement of the community and the general population to create this awareness and to share our visions and the work that has been done in the field. We have one book, as far as I know, on psycho-oncology, which was very intriguing because almost in the end, this book is going to be print, right? And then the editor just called Patricia Pascoal and invited us to write something regarding sexual health in patients with cancer. Of course, we did it immediately, and just to let you know that this is a work that needs to be more shared with the public, and we need to have more resources for patients and for professionals that are planning to work in the field, for example. We have the Portuguese Society of Clinical Sexology with this committee on homosexuology that I'm coordinating, and we plan to, one of the things that we are planning actually is to have these guidelines to provide to our associates, but also to conduct a number of education initiatives and programs also for the public general population to be informed and have access to specific information regarding homosexuality. And then we have associations, professional associations working in the field and providing patients and providing the general population again with information regarding the cancer and treatments and the impact of cancer on sexuality, for example. Well, regarding research, we have been witnessing a growing interest regarding in the field regarding this topic of sexual health in patients with cancer. We found and created this slide just to give you an overall picture of some publications. There are a lot more, I believe, but just to let you know that this is an emerging topic among the researchers, and I think we have very good groups working in this field and creating this visibility awareness of this topic. Under our research group of human sexuality at the University of Porto, which I coordinate, we have cancer and aging, for example, as one of the main priority areas of research. We try, and we have been capturing some funding to do some projects, and some projects very focused on providing evidence-based programs, interventions for patients with cancer, specifically on prostate cancer, colorectal cancer, and in the near future for breast cancer patients. So this is an important resource that I think that can help professionals to start a way for them to start or to initiate these conversations on this topic with their patients, and also, of course, for patients to have this resource and empowerment. So we definitely will need more formal information regarding the general picture of homosexuality in Portugal. And for sure, there's very important the members of this group to organize themselves and try to create these synergies and networking, and I'm sure we can have a very bright future ahead. We are very excited about that. And regarding Portugal, well, of course there's a lot to be done, but I think we are heading a good direction. So thank you very much for your attention.
Thank you, Anna. Interesting as always. Are there any questions? Online? Or here? So then I would suggest we make a 15 minutes break, and then we still have one presentation, and then we start to speak about our ideas as a group. I hope that Iliana will be back then, and that will be very interesting. We will have a look that we have enough time for that. So in 15 minutes we are back. Thank you. And may I introduce now Jona Ingeborg Jonsdottir, and please start your talk, and please present yourself. Thank you.
It's so nice to see you all and to be here today with you. So I want to thank you for getting this time. It's a nice note. I have been working in the field of sexology here in Iceland for a long time, for a couple of decades. And I led the first nationwide study on sexual behavior in the country. And throughout my career, my goal has always been to advance the field of sexual health. And currently, I'm working as a clinical nurse specialist in sexual health at the main hospital here in Iceland, in Reykjavik. But this path towards specialization in the field of sexology, as many of you know, has been challenging at times, especially in my own country, because there are very limited educational opportunities. And the few sexologists we have in Iceland, we have six sexologists in Iceland. They have gotten their education in the USA, in Australia, in the UK, and so on. Our country is big, but with a very small population. I don't know if you know, we are not even 1 million. We are not even 400,000, but we are getting there maybe in the next couple of decades. In Iceland, there are about 1,800 people annually diagnosed with cancer, and majority of them undergo cancer treatment here at the main hospital, the National University Hospital in Reykjavik. It's about equal number of males and females that are diagnosed, a little more females. Our oncological care is publicly funded, and everyone has universal access to health care. Regarding the oncology, there are a couple of strong self-help oncological organizations that have been in the forefront of providing support for people with cancer. The Icelandic Cancer Care Plan, which is our national oncological guidelines, they state that individuals that are diagnosed with cancer and their close ones should be offered on a regular basis screening related to well-being and support. And this should also be offered services accordingly, including sexual counseling. I have progressed in my career into working specifically within the field of oncosexuality, and I have been working here at the hospital for over 10 years. I was in private practice before, but there are a couple of other sexologists that are doing clinical sexual work, but mainly in private practice now. At the hospital, we established a sexual counseling services initially for oncological patients, but I work there as the only employee. And we also have expanded to offer these sexual counseling services to other patient groups. But I'm also responsible for continuing education, and I must say we need more staff. It's a lonely job, but it's a really exciting job. Regarding education in oncosexuality, there is no formal certified education. In the University of Iceland and at the University in Reykjavik, we have some education in sexuality throughout the nursing, in the nursing department, for example. But we also have courses on chronic illness and sexuality at the nursing department, and I have been teaching those with some other people. But I've mainly been teaching healthcare staff here at the university. And I also do some consultation work outside the hospital, mainly to self-help groups. And last January, for example, I organized a workshop for prostate cancer and their partners. And this is a quote from the headline. Once one participant said it was quite an experience having frank discussions about sexuality and intimacy after treatment, but it was well received. Later on in my presentation, I will tell you a little bit about a unique 2-year educational intervention for the staff, oncological staff here in Iceland. And here is one of my co-workers, Thora, who participated in this intervention with me, and it was really nice to see Wood and here, because he was very helpful in organizing or helping us with the workshops. But this intervention, I will tell you a little bit about it later. We have evolved a lot of patient information for sexuality-related issues regarding sexual side effects in oncology in cancer treatment. First, we offered this information on paper. Then there was a period in developing all kinds of a website, and now it's mostly sent electronically to patients after they've been screened for sexual issues. And it's an ongoing project to develop more electronic information for cancer patients, and I'm in the process of doing that now. The self-help organizations and the National Cancer, the Icelandic Cancer Organization, they translated and adopted an educational booklet about cancer and prostate cancer and sexuality from the United Kingdom, which is a really nice one. One study here in Iceland from 2010 showed that quality of life was found worst in sexual and physical domains. So this is nothing new. And this is the educational intervention I mentioned earlier. I was hired 10 years ago to assist the oncology staff here to develop this educational intervention program to improve sexual health services among healthcare professionals, doctors and nurses. And we wrote an article about the sexual health intervention. It was a multi-component intervention. We identified the change agents on 8 boards. We established a sexual counseling service we educate the staff and train. We developed a pocket guide for initiating the discussion. We developed patient information and the website I talked about, both for healthcare professionals and patients. And the intervention was successful in improving the perception of having enough knowledge and training in providing sexual healthcare. But still the issue remained sensitive and difficult to address for a portion of professionals. The best results we got when we offered the workshop, and we concluded that specific training in sexual healthcare, specific workshops should be available ongoing with healthcare professionals in oncology. And 2 years ago, I finished my doctoral dissertation in oncosexuality. The thesis aimed to describe the characteristics of couple-based intervention studies that address sexuality and cancer, and also to develop and test the effectiveness of a nurse-managed intervention face-to-face for women with diverse types of cancer and their intimate partners. I was always reading about descriptive studies describing the sexual problems, and I noticed there was a gender bias. The available intervention studies, they focused mainly on males, so I decided I want to change this gender bias. And one part of the study was to do a systematic review of couple-based interventions, and it showed that there is a current lack of consensus about how couple-based interventions addressing sexuality and reproductive cancer can best be structured in terms of content and so on. But this systematic interview also offered speculative evidence on how the quality of future couple-based intervention research could be improved to benefit the clinical practice. And the results of this my doctoral thesis was described in 2 articles. And the main findings were that the couple-based intervention is beneficial in lessening concerns related to sexuality intimacy in women with inactive cancer treatment, and that the woman and her partner showed improvements in relationship quality and were also more confident about how their own illness beliefs affected perceptions regarding sexuality and intimacy. And I believe that the components of this intervention, which is active listening, validation of the unique couple narrative, and facilitating constructive beliefs regarding sexuality and intimacy, are a powerful tool to help couples manage changes and support overall sexual adjustment in their treatment pathway. It was a really exciting part of my career to do this project, because I can only say it keeps me alive to do this work, because I'm a clinician and we need to deepen ourselves. And this is a quote from an interview in one newspaper with a woman who was diagnosed with breast cancer a few years ago and her husband. And she says in this interview, "Last year we were a patient and a caregiver. Now it's good to be lovers again." And this is what it's all about. You know, it's about the connection, the experience of feeling alive and enjoying that. It's really important. I am really interested in some kind of research collaboration in oncosexuality coming from this little big country with a few opportunities. So I welcome basically all ideas to research. I like the idea already of creating some fellow European clinical guidelines, but let's discuss it. This was not a complete overview, it was just a glimpse into what is happening here. being so few, it's an opportunity, but also it can be discouraging. Oh, okay, I'm done. Thank you.
Pierre. Pierre, your microphone is on.
Pierre.
Okay, thank you very much. Also very interesting.
Pierre.
Pierre Bundil, we hear your radio or phone call maybe?
It's good.
Okay. So, very interesting, very interesting. And I appreciate so much your work as a nurse. As far as I'm informed, is that sexual medicine developed, and even oncosexuology developed from the group of nurses who were so close to the patients, and they realized that sexuality is such an important topic for the patients, and they were the ones who got the first information from the patients about their problems. So I know that nurses played a historically important role in oncosexology and still do, and they should be definitely very much involved in everything what we are doing. And I just spoke with Astrid. It's of course we need multidisciplinary teams in oncosexology, and I would be very interested in your to hear more from your book, Research in Oncosexology, and research ideas. And I did not understand acoustically. You said also something. Is this a collection of possible research ideas which you put together?
No, I have some ideas myself, but what I showed you was mainly the results from my thesis, and I can send you my thesis to anyone who's interested.
Yes, I think that would be very interesting as a base for our work together, because I'm sure there are very interesting ideas. Now let me ask Faisal, you want to ask something, and Astrid too. Maybe.
Can you ask her about the intervention she did in her work? You said
just two questions, Astrid and Faisal. Yeah.
Actually, it's not a question. It's just thank you, Jona. It's nice to see you. And as I always tell you, and I'll tell you now again loudly, that it's fantastic what you're doing. And your job shows that how much a single person can move a whole country. I know it's a small country, but you did it. Yeah. So and that it's very optimistic for this group as well, that so few people can do so much.
Yes, I also want to join in what my friend said about the effort, especially it means a lot that this is initiated by the nursing, by you and the nursing team. I just want to ask, you have put a paper or two on interventions. Can you tell us if this is a cognitive behavioral intervention or psychoeducational intervention, and do you have an outcome on this intervention for the couple? So what is the kind of the intervention, and is there a possible impact or outcome?
Yes, I can go. Yes, I can. In my slides, there are 3 papers describing the results of the intervention, and it's a psychotherapy intervention based mainly on systemic psychotherapy, where we believe that what you think about, what your ideas, your attitudes towards your own sex life and your sexual relationship is what matters a lot. So we have people who are having going through cancer treatment, discuss what's happening in their lives. And we help them to see what's going on, and they decide what they want to do. But it's a systemic psychotherapy.
Yeah.
Systemic.
And did you measure any outcome? Like
Yes, it was beneficial in lessening the sexual concerns of women in active cancer treatment. And they showed better relationship quality, and they were more sure about how the cancer treatment was affecting their sexual life and what they wanted to do about it. And it helped them overall to be better adjusted in their sex life. Yes, that
Great.
was mainly, it was a success.
Thank you very much. Fantastic. Best.
Thank you.
Marianne, can I raise a question or a problem?
Of course.
Okay. What I'd like to ask, or maybe to mention here,
Yeah.
is you are from the nursing spot, and in the, let's say, in the level of the medical specialists, either in gynecology or urology, you find more or less an equal attention from male and female. If you go to the level of treating and caring for the sexual problems, then quite a lot will be on the level of the nurses, the pelvic floor therapists, and the sexologists. And I'm worrying rather much that nowadays, that is 80–90% of them are female. And I have no objection to female, but I really miss the male nurses, the male pelvic floor therapist, for instance, for prostate cancer, and also the male sexologist. And that is something we have to think about if we look to a wider scope of the future.
I think this is
regarding nursing, there are just more female nurses, so it's a proportional problem.
And it is a general development within sexology and also sexual medicine that there are much more women interested and for example, in our Austrian Academy for Sexual Medicine, in the last course we offered, we just had women. So it's a continuous development that you see that the men somehow, I always ask myself, where are they? And the women seem to be more interested, and this is not an ideal development. And neither for the doctors nor for the you have totally right, for the nurses, and also not for the physiotherapists, because we need the men, and especially in this topic we need the men. Yes, we should actually. This is a very important point, and we should even. We could note it as a topic, and maybe could even write a short article about that. It's an interesting topic. But I think, yeah, Astrid, please.
What is the evidence that it's a problem that the men are left out? I think that's an important question. We actually did a small paper on this because we asked our patients whom do they prefer to speak with, and that was prostate cancer patients. And actually they all, not all, but most of them preferred to speak with a woman. So maybe we are making this a larger problem than it actually is. But this could be a wonderful article. Maybe there are national differences. I
tend to disagree with you, Astrid. I think the case you mentioned, that the female doctor and the male patients and the male don't say anything. If there had been a male nurse or a male physician talking about sexuality, then I think it had been rather different.
They were asked before they met the healthcare professionals, so they didn't know the gender of the person they were going to meet.
Okay.
Yeah.
There is one question more. There is one question more. There from
but that's
from Deal. From Deal.
It was raised from before.
Oh, I think
Okay.
now.
Yeah, Alma, please. Alma, and then Faisal, and then Pierre, please.
Yes, it's my experience from pelvic physical therapy practice that I had men from like Egypt in my practice, And he was very pleased that I was a woman, because if he would have been in his own country, he told me, he would never, it would have been like sort of a disgrace, or it would have been awful for him to talk about his sexual problems to a man, a male healthcare provider. So there is some cultural influence there. That's just what I want to share with you, and may vary between countries. But yeah, this is. I just wanted to tell you. That's it. Thank you.
Probably what I want to say something in this regard might go also for the general recommendation of the group. I think at this stage, and again we're not generalizing, it depends. I think at this stage, some of the survivors would probably prefer to get the counseling from the primary physician. If there is a probably ovarian cancer survivor or a breast cancer survivor, there is a primary role for the gynecologist. Same thing with the prostate cancer survivor, and there is a primary role for the urologist before going probably into further levels. So I think now the issue of gender of the provider is still at this stage. I think the most important thing is to engage the providers, like the examples we see from Portugal, from Norway, Italy, and the other European countries, is that we, and this group hopefully, is to bring all the primary providers, and also from France, at this stage, at least to start learning some of the basics of to talk about and counsel about and stuff. And as a gynecologist, I can say the woman will definitely like to hear it from me in the first place, some of the basic information and counseling and where to go, and then probably I would refer to Jonah, Anna, or the others for further. So I think the main function of this group is to really engage the primary physicians of the different cancers or types or tumor types to do the basic engagement with their team, of course. Thank you.
Leslie, could you just put this? Yeah, I think we could now start to speak. We have 20 minutes time to speak about our next steps we could do together and collect good ideas we have. Astrid and I put together in the post a few ideas which I wrote down on a good text. But maybe Ileniak, you want to say first something about that? You put together the whole team, and you I'm sure you have. Thank you for that. Yes, it was a great effort, and really thank you for that. And could you maybe say a few words? And in the meantime, we upload the thoughts of Astrid and me, and add yours, and then we take our first steps.
Okay. Yes. Well, I'm very happy that we all came together, yesterday already, and today to exchange all of this information about everything that's happening in all of our different countries. I think that's very valuable. Of course, I did not do my part about the Netherlands, but in the Netherlands I started also a group like this, but then of course in the Netherlands with all homosexual or actually all sexologists in the broader sense working in oncology and in all of the different fields. And we also have a patient organization that is involved in our group and also give very valuable input, because they also have, I've seen that in some different countries also, and I think in France, a very valuable, they have like ground. Of course, they voice the patient's voice, but they also can make things really happen also sometimes. So, and of course you have people from research, we have people that do the education Wood is in the group. Yesterday Luca was there, Inge is in the group, and also some people from Belgium who are not here now. So now let me get to my point. How I started in Corona time, so that was only online. And I started with, of course, the late Ellen Laan and Wood, asking them, who works in homosexuality actually in the Netherlands? I want to bring them together, make some kind of group, exchange information. What are you doing? So we inform each other. So what we do is we get together 4 times a year for an hour, a very short, intense, not really other subjects, and bring together all the information that people are working in. Like somebody said, some of the pockets of the country, maybe somebody is working, and I want to clear all the pockets and see if I can get it all on the table and for everybody to enjoy. So that's what we do. We come together 4 times a year, and after that, all the information that's gathered gets sent out in a newsletter from my own Dutch sexology organization, the FVS. They of course have a list of people, but we have, I just checked on the website, it's the 7th newsletter already. So in the meantime, because I sent them out too, because I work, so I don't know if everybody knows me, I work in the Antonie van Leeuwenhoek in the Netherlands. It's specialized for cancer patients. So I send them out to all my colleagues in the cancer hospital, and that's what I also ask to all the members of the group. We have those newsletters, send it out, and by this time we have our own database of all people wanting to get and stay informed of all the initiatives and all the information that's put out there in the field of homosexuality, like a reading or some kind of new podcast. Some things go really fast. So every reading I do or every talk I do, I always mention the group, and please go into the newsletter and so you stay informed. So that's kind of how our Dutch special interest group homosexuology works. And from that, and of course with the ESMN, I was asked to say something about our group. And of course came the plan to, well, let's see if we can reach out to all the European different countries, because the ESMN did not have all the homosexuology people as members yet, of course. And with the help of Wood again, with his extensive, how do you call that, things for all the information of all the people, and the data hall, I guess, try to like that. Once again, I reached out to all of you, and that resulted in these 2 meetings in fact the ESMN. What I would have to say is that it's just like the SIG, it is a joint effort. So every
Ilenia?
So maybe we should ignore
Yeah, okay. So, maybe let me just, I do not want to interrupt her, but maybe let me say something.
12 minutes, we'll have the break.
Let me say something. First of all, the Austrian Academy for Sex. Here she's back.
Sorry.
No problem, no problem.
I was going to a closure anyway, so.
Super. But thank you for all your efforts, and it's great that you are here. Although you are not in the best condition. So maybe
I want to say this, the last, an important thing I said was like the participation of all the members is really important. So everybody needs to chip in with some kind of task. It's not something I can do by myself, or it's something we have to do together, and that's why I find it important before we go further on with the discussion that it's that we also together we look at what do we need to make this maybe like something that we do in but we can also do something different. So that will be my question, because I see already like a lot of the people that have presented. Of course, I had other things to do again, and then they left, and that's kind of what happens with groups like these. And my goal for today, to see if we can, how can we make this sustainable? So how can we make this a group that works and that will work for the coming years? So what do we need? I think something like not too much of, not too, yeah.
I understand.
Goals, because if you make really big goals, then people, but also, what do you get out of it? So what would make you come back like twice a year in a Teams meeting, or what does that need to be? What do we all together need to provide each other for it to make it work? That was my final thing.
Yeah, super. May I? Is it okay for you when I uploaded the few ideas Astrid and I gathered in the break? And personally, I want to tell you that the Austrian Academy regularly makes oncosexology webinars, and I would somehow very successful. And I applied again for a medical educational grant in Pfizer, and I have we have excellent chances that we will get that grant again. And I would definitely like to make a connection between these webinars and this group, because it's a really good forum. And also Anna Gomez knows, we also tried already first oncosexological workshops, and they are also, so I would, that was also very interesting. So it might be a good idea to make in late autumn a workshop together where we have already gathered a possible small idea for an international survey or something like that. And then within this oncosexological workshop, Anna, you know them already, maybe again with Eric Janssen and my really also bright brother Richard Greil, who's an oncologist, one could start discussing about such an international survey. And until then, we could gather ideas. So this is an offer I make. We could organize that. And okay, and then Astrid and I just show you, or maybe we are upload. Could you please help me? Sorry. Maybe I upload just a few notes and we speak about that. Could you just upload it as a whole?
So they can see.
Yeah. Okay.
Not just. Give me a second.
I povećaj malo isto.
No, it's just a few ideas. First, we want to make a general statement. We do not want to interfere at all into the ESSM schools. Our team is much more specialized into oncosexology. There shouldn't be any competition. And then we also said we could easily install a member area for this group on our ESMN website. That would be maybe a good idea. And even try, I do not know if we have platforms for upload, but I think we should have one. We should have.
We should be able to.
It should be able. Okay. Then our suggestion is to make a first publication just about these presentations which were done today and yesterday. So this is the status quo, and that would be very interesting. And of course, an Austrian overview would follow. Maybe even Faisal, you could give an overview about what's going on in Lebanon.
Yeah.
And so we could,
Region.
yeah, or in the whole region.
Yeah.
So that could be a first publication, which shouldn't be too difficult. And I wanted to ask you what you think about this idea. Put this together, what you said today, in a first publication of the group. What are your thoughts about it?
Can you precise exactly what you want?
I just would put, we have now these, I think it's 9 or 10 countries, and with the presentation of the status quo of oncosexuality in the different countries, and so that would be just an article about the status quo of oncosexuality in these different countries. At first, it would be very interesting, and it could be a first publication.
Is that something different than like the newsletter I suggested, Mary, again? That from the notes we took, and of course the video that's been taken, that we will make a newsletter to send out to all the members, and for the members to send them out to all of their oncosexological colleagues in their country. Is that what you mean? Do you mean something different?
No, I mean something different. I think it's already very interesting what you presented, and just to put these presentations together in one article. This is what I meant. But sorry, Alma, you want to say something?
Yeah, it's another idea or suggestion, because there appear to be lots of guidelines in different countries, and it might be an idea to make a review article about all the guidelines to see what works, what doesn't, and what's the overlap and what's different. So that might be an interesting thing to do.
Yeah, I think the group has to decide. Of course, that's also interesting. We could write it here too. So may I just?
Sorry, don't you think it would be very interesting, because we knew that in every European country the problems are similar. We know that the patients are on demand, and there are a lot of unmet needs. So I propose to see is in each country of Europe. It's exact that there is a lot of unmet needs to the problem of responsibility. If yes, why? It is a problem of offer, it is a problem of health professional, it is a problem of cost. And third, which solution each country has done or is our own project. So it's not very complicated, and it can give us a global view of the situation in Europe. And by focusing on the main question, the unmet needs, yes, no. What the unmet needs, problem of visibility of the offer, the problem of the education and formation of the healthcare professional, three problem of cost, probably the three are combined, and third position, third problem, third topic is what solution?
Yeah, interesting.
Or in the future.
So, and one could send out this. You would send out that to different to the cancer associations or to different hospitals, or where would you send these questions?
It's difficult because it depends on the organization of each country. But for me, if we agree that the supportive care are the key of the solution, we have to the supportive care in each country, oncologic supportive care. Because there are, in each country, there are specific associations of supportive care, and sexology also, sexology and supportive care. So we have the two components, we have the cancer, and we have sexuality and sexual health. And to add to association, national association. So we have the two legs of the problem.
Okay.
Because if you make a large survey, it will be very complicated. I suppose. It's better to focus on the main responsible, and we have a global view, the Association of Sexology and Association of Supportive Care. For instance, in France, you have the LAFSOS and the youth, and you can have a very good idea of the problem of cancer and sexuality. Because we work together in this field. I suppose it will be the same thing in other countries.
Yeah, thank you. I understand, but I think the priority should be different. Of course, you know much better within the European context than I do, and I think we know very well there are unmet needs. I don't think the problem is to verify if there is unmet need. The problem is to create demand and to position sexual health problems in cancer survivors as a main issue. And that should be worked on with the providers of care, so they put this as a main topic in their counseling and in their clinical practice. And of course, you know better in every country how to make the support of the health system or of the public health system. But for us as a group of providers or professionals, we have to bring this, to position this very high on the list of the clinical concern of those people who are survivors of cancer, rather than spending time on the unmet need, because there is a need. We have to create also this need. We have to create this demand. We have to make this an important aspect of the practice, and I think we should be looking at specific issues in every country. Where better to put this in the leadership, in the hands of the specific group that's called oncosexology associations, or on other hands, depending on the context. But I think the main important thing for this group is to start highlighting and repositioning this very high in the clinical practice.
If I can respond, we must be very careful, because if I take lesson from the French experience, we know we have a lot of survey among the patient, by association of patients, that show that the demand is real. We have a lot of publication showing that every cancer, and male and female, every age, there is a big, huge demand. The problem, if we create the demand, but we are not creating the response, it will be a problem. And the French will be very careful with this. First, we knew that there is a demand, but we must setting up the response, because if you say to people, go to the sexology, go to ask and say, if there are no response, it will be productive, you know.
I agree with you fully. I agree. That's why I said we should start working on the providers. I agree with you, because there is a demand, but you have to create the supply. And that's why this group can do very well on the providers. Sensitize the provider, make the sexual health a priority in the clinical encounter, and train more people about feeling comfortable talking about it as providers, whether they are, as you said, from the GP's level or the primary level to the secondary level. I think this is a priority. I agree with you.
Can I add a little bit, Farzal?
Yes, sorry.
We have, I think, two groups who are important, who are very important in this part of the discussion. One is the patient organizations, and we have the European Patient or the super organization for all Europe. That's one, and they are important to let's say, feed the patients that they could ask questions. But at the other side, we have the professionals. And if I look now to the list we have of countries, if you look at Sweden is not present, Finland is not present, Switzerland is not present, three very rich countries, and there's nobody here. Probably because they don't know the opportunities and to get the support and the motivation to walk into this area. And very big country like Spain isn't present at all.
Yeah.
So I guess also we have to try to bring it a little bit more complete European.
Yes.
Yeah.
Good, if I may make another comment, I think that it's also very good, very nice to engage or involve the European Society for Gynecological Oncology, and they also have their own patient representatives. So there will be an annual meeting in September, the 28th of September in Istanbul. I think it might be very, very nice to also search for collaboration with those societies and perhaps also with the European Society for Medical Oncology, for example. Just to get more people involved, both the professionals as well as the patients.
Yes.
Yes, so there were 2 points. First of all, inviting other countries, that should be easy. We could invite Johannes Bitzer from Switzerland, and he's gynecologist, of course, and he would know who else. We will have a look who else from Switzerland could be.
I'll try to, of course, I'll try to invite all of these countries, but they declined. So
yeah,
I've tried to include all the only countries I did not approach were Ireland and Poland.
Okay, so we can make a list of countries and then maybe have a look together who we could invite from these countries. And then we also should have a look, are we multidisciplinary enough? Do we have to invite more nurses? Which doctors from all bigger disciplines? Or so that should be. So we should think about that too. Sexologists, psychologists, whom else should we invite? From which countries and from which disciplines? And then. So then Astrid and I thought, what could be a future with a shorter perspective? Is the question, what could we learn from each other? And then we also said inclusion of NGOs, patient groups, and then if we want to build up international guidelines in oncosexology, we have to ask, are they already are some already existing? What is the need? Who are the target groups? Patients, doctors, nurses, psychologists, and then
I think, probably if we get the fund, probably 2 main tasks for this group, building on what Bondil also and the others said, is the first would be like compilation of what's happening. That's very important to start with, just to see the world, the seriousness of the issue, and there is something going on in the different countries. And I think the second would be another compilation, like what the WHO is doing in terms of sexual health, is to combine all the look at the international guidelines, make a kind of compendium on the international guidelines that are available, and then see what else you can add to this. And I think another important target, as I said, is to engage in the training and learn from the experience of countries like France, I think Italy and Norway, Portugal, and all those that presented on the training of the provider. I think it's a good start if we have the funding. Maria. Yeah.
With respect to the European Society for Gynecological Oncology, my direct supervisor is the president-elect. So, and my other colleague is now the president of the European Young Gynecological Oncologists. So, if you would like to connect with them, I would be happy to.
Excellent. Excellent.
So, the French guideline, the first one with the ABSOS was not with very high level of scientific control. But the guideline with INCA, with the Institut National of the INCA, was with a very high international level because we have the same control that they do for another for treatment for cancer. So it's a very, very high level. For this reason, as it is transversal, I think it's recent, it's only 2 years ago. it's important to use it and to assess you another contraception if it is correct for each country. Because with the National Institute of Cancer, the labelization for us in France is international labelization. It's the top. There is not more.
Yeah, that's why it's important to look at the different, make a compilation of these guidelines. I think it's important. But I want to talk to Angie. I still believe that the initiation of this new path or new, if you want, specialty should be coming from not purely the oncologists, because they can be collaborators, of course, or can be partners. But this group, because they have the interest in the sexual health from different aspects, like nurses, sexual health, gynecology, sexual health, of course, can be oncology, sexual health, urology, sexual health, midwife, sexual. So it can be much better because you understand the concept of the sexual health and the sexual function and everything. The pure oncologist, they will like the cardiologist and the others, they will have no clear idea what are we talking about. But definitely I agree with you in having them as partners and collaborators, because they reach out to the oncologist, which is very important. Yeah. Do we have do you have anything like the European oncosexology? No, we don't have anything at the European level.
You have two pioneers of the International Society of Cancer and Sexology, which works after I've been.
There is a body on this.
It is sleeping and it died.
It's dead now or it's coma?
It was too soon.
So there is a place for this, if we can call this something like European or something like this, network, also not society. But there is nothing official. Okay.
That's what we're doing now.
Yeah, now of course.
If we want, it can be resuscitated, the International Society of Cancer and Sexuality. It's not a problem, I think.
Yeah, it is.
Young people.
Yeah.
If I may respond to the European Network for or Society for Gynecological Oncology, that was what I was talking about. They are now more and more focusing on sexology. And for the first year in the European exam, there are also incorporated some questions on oncosexology. So it's becoming more and more important. So, but maybe we can just collaborate even more.
Yeah. Also, another suggestion for this group is also whenever there is a chance for upcoming meetings, like for example, I am on the committee for the WAS meeting in November in Antalya, we can have a session on oncosexology, upcoming meetings, whether they are national or European, the one happening in Bologna also, or other places, European menopause. So all these can have a place for oncosexology. As you said, Angie, you start more and more advocating for the, or do you have something happening in Amsterdam also, Dutch society?
Oh, well, I'm in Rome, in Italy.
Italy.
I am from the Netherlands, that's true, yeah.
Yeah.
Good. And what about the patients? But I don't really know what stigmas experience is in Italy, but
mandatory. It's mandatory. We must have patients. Now it's not possible to do something for the cancer without the patient integration of patient association. We must have in our when we make our French guidelines, we have two patients in our working group officially.
Yeah, very nice. I agree.
Would anybody be interested in writing some kind of a letter to the editor or a review or some paper on the oncosexology? I'm happy to be part of this. If somebody is interested, we can send it to the FIGO journal, we can send it to the GSM, or I'm also on the editorial board of GSM. So or as a group, we can have it as a group paper, looking at and highlighting the importance of oncosexuology if you want. Just a suggestion.
If you want a provocative article,
yes,
I can do a provocative article. Just to not take care about sexual health in cancer. It's a fault. It's a mistake.
Yes,
and
we can make it as provocative as we can. Yes, of course. I like provocative.
That would be also, I think, very good with this.
But Marianne, if you think this is a good idea, we can do it as we can have like 3-4 leading and the others contributing. We can make it a joint article.
I think we have.
I would be very happy to collaborate, and just let me say one thing. Because I'm new in the group, so I don't know every detail. I think we should first organize ourselves to be recognized as a formal group.
Totally right.
So
yeah.
That is very important, so we can then start positioning ourselves regarding homosexuality.
Yeah, I agree. We're just saying suggestions now. Yeah, of course.
Oh, perfect.
We have to make ourselves like one piece.
Yes. So I would say that would be our first
and
step.
have a nice name. Have a sexy name.
And also maybe if we want to think about a future publication where we would highlight and compare the different countries, maybe we could think, and we can do that easily, about the international survey that we could use some of these topics that we addressed today, like the guidelines, training, education, services, working, professionals, and the representative of each country could be responsible to contact local organizations, associations, different professionals working in the area, and have this more structured and formal information retrieved, so we could do this mapping of all these topics in the homosexuality field for each country. Maybe that could allow us to compare in a more formal way, in a more adequate way, and characterize how homosexuality is working in each country. Just a suggestion.
It is a good suggestion, Anna, but to whom would you address these questions? Because who has an overview? For example, I wouldn't know to whom in Austria ask these questions. To get a total map of what's going on in Austria would be very difficult, and I think it will be not so easy. Maybe other countries are better organized. We are not organized enough, I must say.
I would say we could start with the associations, so medical associations, psychologists, nurses, and contact them directly so they can spread that survey among their associates. That would be a way for you to have these professionals engage in completing this survey. So, for example, have you ever had training in homosexuality, where papers, do the research, where you practice, so we can have this more clear picture. That could be a way of doing that, targeting the professionals, I would say, at this stage. So we then can see the needs that professionals have and their level of preparation, which is very different among the different countries. So maybe we could have some more clear cooperation regarding the countries, identifying professional needs, and then we can start thinking about how to address this and all the guidelines and training.
Super. I also agree with you that we should first, and I'm sure that Astrid and Ilenek are of the same opinion, that we should first consolidate ourselves and as soon as we have found our identity, then we can go out. That would be the next step. I agree with you totally. We are a little bit late already, and I would say, Ilanek, are you still there? Maybe you say.
It's lunchtime.
Yes, I'm still there, but.
Because I think we have to stop now because lunch has already started 20 minutes ago. So maybe you could say some words for at the end. We will certainly put the minutes together and all we discussed and send it to the group. And all the suggestions came. And we can even make a row of importance, and we can, of course, continue to discuss the next steps. But Ilanek, maybe you say, as the leader of the group, something to end the session.
Mariana and Ilanek, just a very short question in between. Are we going to call ourselves the European Task Force of Homosexuality or the European Collaboration of Homosexuality Professionals?
This is something we can think about. European Task Force sounds very, very strong. We can put that. We can put the name also into the as a discussion point. For me, it's important that that this group stays a member of the sustainable of the future ESMN. That would be very important for me, and I think it would be also good. And we discussed that yesterday, but I think the name we can discuss that in any case. I will make we will write the minutes and send it out for further discussions.
I propose a co-construction. Co-construction.
A co-construction.
We are doing co-construction.
Mm-hmm.
What do you mean?
It's important to have in the name. It must be a transversal and multidisciplinary and transdisciplinary approach. This is mandatory because we are in sexuality and in cancer. It's not urology, gynecology. It must be transversal. For this reason, supportive care is not very good, but co-construction, I think, is very well. Multidisciplinary also.
Yeah.
Yes.
And transdisciplinary, because this is the problem of it.
Okay.
It must be in joint.
So from my side, I say goodbye, and Ilanek, maybe you say it. Is not there anymore. So may I say?
Yeah, sorry, my battery ran out, but I checked in again.
Okay, just could you just end the session?
Yes, well, I'm very glad everybody's here and dedicated their